will be heard. So they're just about to go live.
And Sean, I guess my camera will go live at that time too.
Lee, is that you?
No, this is Nelson.
Oh, Nelson. Well, you'll have to switch on. So,
Yeah, okay, because it says I can't right now. I just wanted to double check.
Oh, yeah, let me do that. Let me make sure everybody can turn their video on. Hang on a second. Okay, just a moment. There you go. Okay, so any of the panelists, you could test your video real quick. Just start and stop. There we go. I'll stop sharing for just a moment. There we go. Okay, great. Looking good. So I'm going to turn off Lee's video for now.
Hi, Carol. Thanks for joining.
Happy to be here. Looking forward to it. I'm just checking all my tech.
Yep, looking and sounding good.
Great.
We had a question come across in the chat. If anybody is asking if it hasn't been made explicit, yes, when it's time to share, you'll just click share and share your screen as you normally would in a Zoom. We've enabled that for all panelists. I've disabled the chime. 10 minutes, everybody.
Carmen, can you send out the Survey Monkey to me again?
Five-minute warning, everybody. Okay, recording is live. 4 minutes, everybody. Okay, we are live.
Hi, everyone. I'm Nelson Su, the Residency Program Director here at UCLA Department of Orthopedic Surgery. On behalf of our chair, Fran Hornacek, and everyone here at UCLA, I'd like to welcome you to the Orthopedic Research and Education Foundation's 2020 California Resident Research Symposium. While we wish we could welcome you here to UCLA, we're really grateful to the OREF for this opportunity to celebrate really some outstanding work done by residents throughout the region. In addition, we have a wonderful keynote speaker, Sam Morshed, a real leader in global health, who's going to give us a talk about that after our resident presentations. I'd also really like to acknowledge and thank our moderators and judges who are doing double duty. Rafi Avidian from Stanford, my colleague Nicholas Bernthal from UCLA, Adam Lee from USC, and Carol Lynn from Cedars-Sinai. One of the advantages of being virtual is that I think the residents will be happy to hear we do have a lot of monetary prizes to give out today. We have 6 awards from the judges and 1 that the residents will vote on themselves, which is something new. The prizes will total $5,000. So we're really excited to host it and see your great work and reward that. I think the first time I went to these was well over 10 years ago. Several of our residents are there and several residents from around the country, and it was down at UCI. I've seen these people go on to great things, and I'm certain that will be true of those of you that are participating today. So to get us moving along, I'd like to turn it over to Lee, the Chief Executive Officer from the OREF, for a few introductory comments.
Thank you, Dr. Suhu. Before I go on, I want to extend my sincere thanks and gratitude to you and Dr. Horacek to the David Giffen School of Medicine at UCLA, and specifically the Department of Orthopedic Surgery for so graciously agreeing to co-host this event with OREF. The participation and engagement of our regional hosts adds immense value to these symposia and have played a huge role in their success over the years. I also wish to thank our numerous sponsors whose names you will see throughout the day. We are grateful to all of you for your support. So good morning, everyone. I'm Lee Grossman. I'm the CEO of the Orthopedic Research and Education Foundation, or OREF. On behalf of the OREF Board of Trustees, I want to welcome you to the 2020 OREF California Regional Resident Research Symposium, which is our first ever virtual symposium. I also want to note another first, and that's that this symposium is being live streamed via OREF TV, our new internet video platform. We are thrilled to have so many incredibly talented resident clinician scientists presenting today. We are also honored to have an esteemed panel of judges who will score and select today's winning presentations. And speaking of first, this is the first resident research symposium where the resident presenters also have the opportunity to score their fellow presenters. For those of you who may not know or be familiar with OREF, we are an independent, nonprofit foundation that provides research funding to researchers and clinical scientists across all subspecialties of orthopedics. In just the last 5 years, we've awarded nearly $12 million, and since our founding in 1955, we've provided nearly $150 million in grants and awards. Our funded research has led to some of the most important breakthroughs in orthopedic clinical practice, and the work we are doing today has never been more important or significant. The money we use to fund these grants and programs are the result of the generosity of you and many other orthopedic surgeons. OREF is a strong investment in your current and future profession, and we cannot thank you enough for your support. While we have special interests in helping early stage investigators establish themselves, we offer funding opportunities for investigators at all levels of experience. If you're interested in learning more about our upcoming grants, please visit the OREF website. It's very simple to remember. Just go to oref.org/grants. If this is your first taste of an OREF Resident Research Symposium, we've been offering these events for more than 20 years. We generally do several a year, which means conservatively, we've probably heard about 1,500 resident presentations in that time. That's a lot of research. But in all seriousness, though, I've been the CEO of OREF for just over a year now, and I've heard about 50 of these presentations in that time. I can say with all sincerity that these are impressive young researchers, and most of their presentations have applicable clinical relevance. To those of you presenting today, thank you for your participation and good luck. Based on my review of the abstracts for today's presentations, the future of the orthopedic specialty will be in very, very good hands. I'm excited to be here with all of you today and to listen to these outstanding research presentations. So without further ado, let's get the presentation started. Thank you.
Thanks, Lee. So I think just a reminder for everyone on the format, we'll be giving 4-minute talks each resident, and we have divided them into sessions, and we'll have the moderators lead a 10-minute question and answer session after each section. So Rafi, Dr. Vidian, can we go ahead and get started with session 1, please?
Great. Thank you for having me. And I think we'll dive right in. It looks like it's going to be a great program. So our first presentation is by Dr. Daniel Gregg from UCLA. And the topic will be stem tip location represents a potential modifiable risk factor for aseptic loosening following cemented distal femoral replacement.
Thank you. I am just going to share my screen here, although it says that host has disabled attendee screen sharing. So I'm not allowed to share my screen.
Sean, are you able to address that?
You should be able to now.
Stand by.
Okay, there we go. All right, good morning, everyone. I'm happy to kick off today's presentations with my talk on risk factors for aseptic loosening of cemented distal femoral replacements. With advancements in imaging, medical therapy, biomaterials, and surgical technique, the prognosis for patients who undergo limb salvage surgery for musculoskeletal tumors has continued to improve. Aseptic loosening has been cited as the most common cause of failure of endoprostheses at long-term follow-up, leading to significant patient morbidity and challenging revision surgery, especially following distal femoral replacement. Several studies had demonstrated increased resection length as a risk factor for loosening, though this is generally dictated by the extent of the underlying tumor and is thus not easily modifiable. The objective of this study was to utilize a large database of primary cemented stem DFRs with up to 40 years of follow-up in order to identify risk factors associated with loosening. We hypothesized that a stem tip location in the proximal metaphysis would be associated with an increased incidence of loosening, and thus aimed to create a simple binary reconstruction guide to aid in templating these complex procedures. A retrospective review of all consecutive primary cemented stem DFRs performed at UCLA since December 1980 was performed. The primary outcome of interest was aseptic loosening requiring revision of the stemmed components, defined on imaging and confirmed with intraoperative stress and negative operating room cultures. Stem tip location was defined on AP radiographs as diaphyseal or metaphyseal based on its location relative to the distal aspect of the lesser trochanter, as shown here. 245 patients were included for analysis, with an average follow-up time of 12 years. The most common underlying diagnosis was osteosarcoma in 68% of patients. Modes of failure were analyzed according to the Henderson method. Both aseptic loosening and structural failure were the most common causes of implant failure, each with an incidence of close to 12%. A multivariate analysis identified risk factors for the development of loosening: younger age at the time of surgery, male sex, longer resection length, non-modular or custom implants, and longer follow-up time were all significantly associated with aseptic loosening, while stem length and width were not significantly different between groups. 15-year survival to aseptic loosening was 86% for resections less than 20 centimeters, compared with only 29% for resections longer than 30. Modular implants demonstrated improved 25-year survival compared with non-modular or custom implants, as shown on this Kaplan-Meier survival curve. Following one-to-one matching for the previously identified risk factors, a metaphyseal stem tip location was found to be independently associated with the development of aseptic loosening. In fact, 36% of patients who went on to loosening had a metaphyseal stem tip versus only 8% of patients whose implants did not fail. Indeed, 30-year survival was diminished for stems ending in the proximal metaphysis compared with stems ending in the diaphysis. In conclusion, this study found that aseptic loosening is a prevalent cause of implant failure in the long term and identified a metaphyseal stem tip location as an independent risk factor for its development. When traditional long stem fixation would end in the proximal metaphysis, alternative or supplemental methods of fixation can be considered. Such alternatives include cross-pin fixation, as shown here, and compress techniques, which allow fixation into short segments. As such, the results of this study can aid surgeons in preoperative planning for endoprosthetic reconstructions by using stem tip location as a gauge for when use of a cemented stem alone may place a patient at undue risk of loosening. Thank you very much for your time and for the opportunity to present this work.
Thank you. Very nice presentation. So we'll move right along to Dr. Obiajulu Agha from UCSF. We'll be presenting on human rotator cuff tears have an endogenous inducible stem cell source capable of improving muscle quality and function after rotator cuff repair.
Hi everyone, let me just share my screen. Okay. Hi everyone, welcome to my talk. So the rotator cuff tears are extremely common and expensive problem encountered by orthopedic surgeons every year. About 250,000 of these undergo repair annually at quite the cost. A key determinant of whether or not the success of this repair goes forward is whether or not
so
the muscle quality of the
you're
RC.
not really going to have as much mobility in your arch. I think I remember
Can we
hearing
ask
about
that
the limbless
everyone mute if
mechanism
you're
and
not
how
presenting,
as you
please?
bend, that arch should increase when you dorsiflex your M2P joint. So I think that might
Is there a way we can mute
pain
all
or just
folks,
diminish
please?
function of your arch.
Oh, okay, I'll keep going.
Oh, but you're on mute now. We're gonna have to unmute you.
Am I muted now?
Yeah, you're unmuted. Why don't you just go back a
Okay.
couple slides just to, I want to make sure that we,
Sounds good. I'll just reset.
yeah, thanks for doing that.
All right.
So it's good. We're gonna get
Yeah.
all our technical failures out of the way soon. So then smooth sailing. So thank you. Well, I'll turn it over to you.
No problem. So yeah, welcome to my talk titled Human Rotator Cuff Tears Have an Endogenous Inducible Stem Cell Source Capable of Improving Muscle Quality and Function After Rotator Cuff Repair. So rotator cuff tears are extremely common and expensive injury encountered by orthopedic surgeons every year, and about 250,000 of these undergo repair annually. These injuries are complicated further by high rates of re-tear after repair, and the key determinant of the success of the repair is the quality of the RC muscle at the time of injury and repair. And this has historically been described in terms of the amount of atrophy and fatty infiltration present in the muscle. Many studies have found that with increasing levels of fatty infiltration and atrophy, that the rotator cuff patients had high rates of re-tear, and that they had worse shoulder outcomes and shoulder function in both operative and non-operatively managed patients. Furthermore, after repair, many of these patients have progression of the fatty infiltration, and this is correlated with high rates of re-tear. So in order to improve outcomes in these patients, we like to address the quality of the RC muscle. In terms of the pathophysiology behind fatty infiltration, it's primarily composed of white adipose tissue and is driven by a resident muscle stem cell population called fibrodipogenic progenitors, or FAPs for short. And early after injury, these FAPs rapidly proliferate and initially provide pro-myogenic signaling for the muscle to aid in regeneration. However, over time, these cells differentiate into adipocytes and fibroblasts, becoming the main source of intramuscular fibrosis and fatty infiltration. However, recent studies by our lab have found that FAPs have the ability to transition to beige or brown fat, which may have pro-myogenic function beyond its thermogenic role, and that its utilization in our mouse model of RC repair and of tear and repair found that it had improved shoulder function and was able to reduce the amount of RC atrophy and fatty infiltration and fibrosis as well. So the purpose of this study was to evaluate for the presence of FAPs in human RC tears and for its ability to transition into a beige fat phenotype. So 20 patients from our institution who were undergoing RC repair were enrolled. And you can see the data of the demographics in the table on the right. And supraspinatus biopsies were obtained at the time of surgery, as were deltoid biopsies to serve as controls. The degree of fatty infiltration and fibrosis was quantified in the muscle, and then FAPs and stellate cells are quantified using FACS across different tear sizes. In addition, we analyzed the FAP gene expression after culture in fibrogenic and adipogenic media, and after treatment with amibegrone, a beta-3 agonist known for its ability to induce a beige fat phenotype in adipocytes. So in terms of results, you can see here that the muscle from the full thickness supraspinatus tears contained much higher levels of fibrosis as seen in the blue stain, and a fatty infiltration as seen in the red stain, much more so than partial thickness tears and from the deltoid biopsies as well. Furthermore, as the tear size increased of the rotator cuff, we also saw an increase in the FAP number. However, there was no difference in the stellate cell number across tear sizes. In addition, FAPs from the full thickness supraspinatus tears were more fibrogenic and adipogenic in cell culture, more so than the partial tears. And the amibegrone, the beta-3 agonist that I mentioned earlier, was able to induce a beige fat phenotype characterized by increased UCP1 expression in both sets of cells, but more so in the cells from the full thickness tears. And this was confirmed in our PCR data as well. Here you can see that the amibegrone was able to induce robust gene expression changes, including increased UCP1 expression indicative of a beige fat phenotype, and drastically increased levels of pro-myogenic growth factors, such as follistatin and IGF-1. So in conclusion, the human RC muscle contains FAPs, which increase with tear size, indicating that they're the likely source of human RC tear infiltration and fibrosis. In addition, these FAPs retain their plasticity even in large tears and are capable of a BAT phenotype induction. Furthermore, these cells express high levels of pro-myogenic genes, which may be utilized to drive RC regeneration. So additional studies are warranted to see if beige fat can be a mechanism to drive RC regeneration while reducing fatty infiltration and fibrosis in humans. I'd like to say thank you to my mentors, Dr. Feely, Kim, and Lou, and all the members of the Feely Lab and the UCSF Department of Orthopedic Surgery. Thank you all.
Great, nice job, thank you. So we're gonna move on to our next talk is Dr. Joshua Spears, who will be talking about intramedullary fixation of both bone form fractures in children and adolescents. Healing correlates with development of the olecranon apophysis.
Okay, my name is Joshua Spears. I'll be presenting intramedullary fixation in both bone forearm fractures and how it correlates with the olecranon apophysis. We all know that forearm fractures in children is very common, and most of the time these fractures can be treated by closed means. There are some indications for surgery, and we know that intramedullary fixation is normally very successful. But there has been some more recent data in the last few years that showed that there's an increased rate of delayed union in older children and adolescents. So this is our goal of what we want to have happen, and this is what we want to avoid. The purpose of this study was to determine which children had a higher rate of risk factor of going on to delayed union in order to help the surgeon decide when to abandon intramedullary fixation and opt for plate fixation. In order to do this, we used the DiMaglio modification of the sole grain method. And we focused on the olecranon apophysis as it's easily visible on the lateral radiograph of a forearm. And our methods were to collect all both bone forearm fractures, excluding a few of the pathologics, Montesia, Galeazzi variants, and to look at the olecranon stage at the time of surgery and compare it to whether they developed a delayed union, which we defined as union that failed to achieve union in greater than 12 weeks. We used a receiver operator curve to identify a cutoff value of the olecranon stage in order to create groups that would predict the odds of having delayed union, and a logistic regression analysis to determine the odds of having delayed union amongst different olecranon groups. We had almost 1,400 both bone forearm fractures in the study. 63 were treated with intramedullary fixation. The olecranon apophysis was visible on every lateral of the forearm. The receiver, after performing the receiver operator curve, we determined that there was a cutoff of olecranon stage greater than 3, which was a significant predictor of increased rate of delayed union. And the regression analysis showed that for every unit increase in the olecranon stage, there's a significant increase in the odds to delayed union. So with this divided our group into these two groups, that of the more immature olecranon and the more mature olecranon. And we then separated our data based on those two groups as determined by the ROC curve. And it showed here that not only was there a significant difference in the time to union, but there was a very large increase in the number of delayed unions with the more mature olecranon stages. So the more immature, only around 8% went on to delayed union, where almost 50% went on to delayed union in the more mature olecranon stage. Other things that came out of the data is whether the fracture was opened, either traumatically or surgically, did not affect the risk of developing a delayed union, and all delayed unions occurred in the ulna. There are some limitations of the study. It was done at two large children's hospitals. There was some variations in surgeon technique. And our definition of delayed union is much more rigorous than it is in adults. We felt it was appropriate as children have a very robust healing potential. So in conclusion, time to union of both bone forearm fractures in children does correlate with the stage of the olecranon apophysis, as described by DiMaglio. And we would recommend considering plate fixation over intramedullary fixation in children and adolescents with both bone forearm fractures that are nearing skeletal maturity, which can be assessed easily looking at the olecranon apophysis. Thank you.
Nice work. So we'll move on to our next talk. Dr. Liam Bosch from Stanford University will be talking about one-stage durable functional prosthetic spacers are an option for treating periprosthetic joint infection after total knee arthroplasty.
All righty, thanks, Dr. Vidian. I'm having trouble sharing the screen right now. I'm not sure, Joshua, if you're able to unshare, I might be able to share my screen here. All righty. My name is Liam Bosch. I'm a PGY4 at Stanford, and I appreciate the opportunity to be here. I'll be presenting my work titled One-Stage Durable Functional Prosthetic Spacers Are an Option for Treating Periprosthetic Joint Infection After TKA. So in the setting of subacute or chronic PJI after total knee arthroplasty, the gold standard is a two-stage revision. However, two-stage revisions represent a significant burden for patients, both physically and emotionally. Durable functional prosthetic spacers are a previously described single-stage method for treating TKA PJI using primary TKA components and high-dose antibiotic cement. And the purpose of this study was to review our experience with DFPS revision for total knee arthroplasty PJI and compare those outcomes with a matched cohort of patients undergoing two-stage revision with a static cement spacer. So briefly, in terms of surgical technique, the original implants are resected, followed by a thorough debridement and irrigation. The surgical field is redraped, surgeons rescrub, and new instruments are obtained. Each bag of cement for reimplantation is mixed with 4 grams of vancomycin, 4.8 of tobramycin, and 2 milliliters of methylene blue. And a total of 5 bags of cement are used. A primary cobalt chrome total knee arthroplasty component is used for the femur, and an all polyethylene PS component is used for the tibia. So in our study, we had 20 patients that underwent DFPS revision and 28 that underwent two-stage revision with reimplantation. We matched these cohorts by sex, date of surgery within a year, BMI, and McPherson classification. Outcome measures included implant survival, infection eradication, and knee society scores. And survival curves were constructed, Kaplan-Meier survival curves were constructed with survival defined as remaining free of revision or reinfection. So at final follow-up, there was no difference in mean knee society scores between the cohorts. There was also no difference in rates of persistent infection or implant retention. And there was no difference in post-op medical or surgical complications or mortality. So on the left is our survival curve with failure defined as repeat surgical intervention or evidence of persistent infection. And there was no difference between these groups at 50 months with chance of survival of 84% for the functional spacers and 87% for the two-stage revisions. On the right is a survival curve with survival redefined to include patients that had a clinical discussion regarding revision surgery for things like loosening or instability, taking into account the fact that the functional prosthetic spacers are implanted with high-dose cement and are likely to loosen. And so at 50 months with this redefinition, you see that the survival of the functional spacers drops to 47%. However, the overlapping shading does indicate that this did not reach statistical significance. So unfortunately, two-stage revision for PJI is associated with significant morbidity in a patient population that's often very frail, and low-demand patients may be able to retain this functional spacer indefinitely and avoid a second surgery. For those that are more robust and wear out their spacer, they still have the option for revision at a later date. And from this study, we concluded that durable functional prosthetic spacers are an acceptable single-stage option for treating TKA PJI, being non-inferior to two-stage revision at short to midterm follow-up with similar rates of infection eradication, implant retention, and functional outcome scores. Thank you.
Thank you. Nice job. So we'll move on to Dr. Kristen Combs from Harbor UCLA. And the title of her talk is Combined Motor and Sensory Neuromonitoring for Cervical Spondylotic Myelopathy Surgery Causes Confusion, a level 1 diagnostic study.
Good morning. Good morning. My name is Kristen Combs. I'm a third-year resident here at Harbor, UCLA. And I'll be presenting this morning on the utility of neuromonitoring in cervical myelopathy patients. I'm a third-year resident here, and I thank you all for the opportunity to present this morning. So just a little background. Major intraoperative neurological events are important complications in spine surgery, and we look specifically at cervical spondylitic myelopathy patients and their procedures. And we looked at neuromonitoring and evaluated the efficacy of motor and sensory evoked potentials and tried to determine the accuracy of these measures. In the literature, this has been heavily debated, so we wanted to assess whether or not this had value at our institution. So we set out to evaluate the sensitivity and specificity of our neuromonitoring for these procedures and determine what the intraoperative value was. The study is novel because it included only cervical spondylitic myelopathy patients and included both anterior and posterior approach procedures. Our hypothesis was that intraoperative neuromonitoring would add setup time and cost with little benefit in preventing neurologic complications for the patient. So we included 540 patients over a 10-year data collection period. Again, anterior and posterior approach procedures were both considered. Neuromonitoring alerts were considered positive if there was a loss of amplitude of greater than 50% or an increase in latency of more than 10% for 10 minutes. And we compared the patient's preoperative and postoperative neurologic exams with our findings using intraoperative neuromonitoring. So throughout this 10-year data collection period, we had 7 false positive neuromonitoring alerts, and all of these were turned out to be motor evoked potentials. The false positive rate for anterior approach procedures was 1.37%, and for posterior approach was 1.27%. The sensitivity turned out to be 0% for this use of neuromonitoring, and specificity was 98.7%. Here's a contingency table outlining these again, highlighting the fact that there were 7 false positive neuromonitoring results, and all of these were in motor evoked potentials, and 0 false positive or false negative results for the sensory evoked potentials. Again, this is a table just outlining all of our 7 cases, highlighting the fact that they were all motor evoked potentials, and detailing the specifics regarding the case. And of note, these motor evoked potentials were alerted in various times during the procedure, including dissection, instrumentation, positioning. So it had varied alert times throughout the procedure. So we concluded that neuromonitoring added setup time and cost with debatable utility for the surgeon and for patients. And 1.3% of cases that were performed had disagreement between motor and sensory evoked potentials. So surgeons need to weigh the benefit of using neuromonitoring, and our study leads us to think that it may not be as valuable as what people intend. And this can cause some confusion on this case of the surgeon on whether or not to proceed with the procedure, potentially remove good hardware, or do anything else that they may need to do if an alert becomes positive. This may add reassurance on the case of the surgeon, and a lot of people have talked about medical legal benefit as a common use and reason that they proceed with neuromonitoring if a case does end up coming to legal suit. So I want to thank everybody for allowing me to present this morning, and specifically my senior mentor, Dr. Kevin Rolfe, who's our attending and project mentor for this project. Thank you very much.
Nice job. So we'll be moving on to our final talk for this session. This will be Dr. William Rubenstein. And we'll be talking about rapid improvers and resistant responders after shoulder arthroplasty, analysis of patient recovery trajectories using latent class growth modeling. I'll turn it over to you.
All right. Hopefully everyone can hear me. Thanks for having me. So I'm going to be talking about
Your audio's a little spotty there.
resistant responders, steady progressors, and high performers, patient recovery after total shoulder arthroplasty. So total shoulder arthroplasty results in significant improvement in pain and function in the majority of patients, but little is known actually about the degree of patient variation in the recovery process following total shoulder arthroplasty. So the purpose of this study was to classify patients into different subgroups based on their specific recovery trajectories after total shoulder arthroplasty, whether they recover more quickly than others, whether they initially do very well and then start performing poorly, and then to determine patient-specific factors that predict a given trajectory. So the data was collected from a prospectively collected multi-surgeon single-center shoulder arthroplasty database. We included patients with a minimum of 2 years follow-up, and we excluded infections, revisions, and hemis. And latent class growth modeling was used to divide the patients up into specific recovery classes. So the latent class growth modeling is kind of the key to this study. It's a statistical method to evaluate heterogeneity and outcome patterns, and is able to model different recovery patterns for different subgroups of patients. So basically, this tries to take a whole cohort of patients instead of looking at the overall average of these patients. It tries to figure out, more individual or unique recovery patterns and to group patients into groups or into classes that have similar trajectories. For the model selection, it's complex and it involves maximizing class detail. So it's better to have more individual classes, but you also want to maintain accuracy in your predictions, meaning that every class should fit the data well and be accurate. So this is one of the main ways in which we selected the model. So we ran the model 6 times. So what that means, we ran it with one class, meaning the whole group together. Then we divided them into 2 classes, then 3, and so on until we had, at the last run, we had 6 individual classes. And these are information criteria. There's AIC and BIC, which are 2 different types, which are similar. What you look for here is, you can see in class 1, they're very high. The lower they are, the more accurate your models are. What you look for is a plateau. You can see when it gets down to class 3, it then kind of goes back up with class 4. So we ended up selecting 3 different classes or groups of patients for our model. And there were some other criteria that we looked into in terms of size of classes and probability that a given person would be in a different class, which for the purposes of this presentation, we'll pass over. So these are our results in terms of the 3 classes that we determined. So class 1, which we called resistant responders, had low baseline scores and then didn't really improve that much over the course. That's ASES score on the left, and then on the bottom you can see the different time points of follow-up. Class 2 were steady progressors, which had a moderate baseline and then improved somewhat, what we called moderate final results. And then class 3, which we called the high performers, these started out at a moderate baseline, so actually had a very similar baseline to those in class 2, but then as you can see, over the course of time, they improved more and had higher ASES scores at the end. So we're calling these moderate baseline with excellent final results. So one of the analyses we did after this is we wanted to try to determine what puts someone in a given class. And what was very interesting was class 2 versus class 3, where you have people who seem very similar at first, but some do better than others. We looked at a few different measures here to try to assess if there were any differences between the classes. And one of the main ones that we found here were both with diagnosis and type of arthroplasty. So what you can see is in class 3, these high performers, they have a higher percentage of OA as the cause versus, rotator cuff tear arthropathy in class 2. And, correspondingly, class 3 had a higher percentage of anatomic total shoulders versus reverse, as you would expect given that underlying diagnosis data. Although overall reverses were more common in both groups. A couple other results that we found, all 3 classes had statistically significant improvements at 2-year follow-up as compared to baseline. However, when you look at the minimal clinically important differences, only 25% of patients in group 1 met that criteria versus 77% and 92% in classes 2 and 3 respectively. And then the other thing that we noted were all significant improvements in all classes were achieved by the 1-year time point, meaning after 1 year, we didn't really see too much, any improvement. So it's kind of where you are at 1 year is potentially where you're going to be, and there's not necessarily much room for further improvement or intervention at that point. So future directions for this research, continue to work on predicting patient factors that lead to placement in a given class. given the things we looked at so far, there may be certain things that we're not measuring that would lead one to fall into a certain class. And then also, identify interventions ultimately that can help a patient move from one class to another. So we want to know if someone's heading towards being a steady progressor, maybe we can help them become a high performer. So thank you very much. And I just want to thank all my co-authors, co-investigators on this project.
Great. Nice job. Looks like we have a few minutes for question. And I'm going to take a look at the chat here. And I believe Dr. Sue has a question for Dr. Rubinstein. Innovative approach. I was wondering if the diagnosis basically accounts for the class for most patient, or if you are really seeing a group of factors defining class. You can see the question in the chat there.
Sure. Let me open up the chat here. Does basically counts for the class. No, I don't think that the diagnosis leads to the class, because class 1 also had varying diagnoses. I think it shows that that's potentially a major factor, but I don't know if we can 100% say that, just because it's OA versus rotator cuff arthropathy or an anatomic versus a total, that leads to a given class. And that's based on, a lot of the studies that have been done prior, we don't see any differences in terms of outcomes with ASCS scores between total shoulders versus reverse, or necessarily between like OA and rotator cuff arthropathy. So I think that, based on that prior research, I don't think that necessarily explains the differences in outcomes, because we wouldn't expect to see that.
Nice. So yeah, if anyone has any questions, please go ahead and put them in the chat function. And while we're waiting, I'd like to ask Dr. Spears about the forearm fracture study. So very nice work, nice, just kind of a nice, elegant little study there. And I was wondering, just, do you think there's a difference between using just chronological age versus the olecranon apophysis scale? In other words, could you use either one at age versus the apophysis mineralization, or what's the benefit of using the apophysis compared to age?
Yeah, I think this comes up a lot. It comes up in scoliosis in kids. It comes up with a number of things where we use skeletal markers over age. I think this is just another data point that you don't have to look for, right? You're going to have a lateral of the forearm. You're going to be able to look at the apophysis and just get another read. I think most of the time age and skeletal maturity correlate, but there are definitely children where it doesn't, and times when it doesn't, where kids are either delayed for whatever reason. And it's, if you, like you said, it's a simple little thing we found, where when you're evaluating the x-ray and choosing the surgery you need to do, you can just look at the apophysis and kind of give you reassurance and correlate that with the age to make a better decision.
Nice, thank you. We have a question in the chat box there, and I'll read it out. This is from Dr. Bernthal to Dr. Bosch. How are patients selected for single stage versus 2-stage in your study? It was retrospective. Can you speak to potential selection bias?
Absolutely. So you're right. It was a retrospective study, and the way that these cohorts were created is that one of our arthroplasty attendings uses this for every single total knee infection, regardless of whether or not we have an organism preoperatively, if we do, how virulent that is. Some of the other single stage factors that are used are not regarded for this. And the 2-stage cohort is 2 of our attendings who predominantly use static cement spacers. And so it was just the difference in attending preference, and we were just comparing their patient cohorts. And we did look at things like organism distribution between them, and they're similar. And so there wasn't really a difference between the cohorts, although it was retrospective.
Thanks. I think with that, we'll come about almost 8:42, and so I'll turn it over to my colleagues, and thank you to everyone in the first session. I think it was a really nice set of studies and very well presented by everyone. Thank you.
Thanks very much. Nick Bernthal from UCLA. I'll moderate the next session and try, as in all things, to model my behavior like Dr. Avedian, who runs right on time and ran a perfect session. So let's jump right in, 8:42. The first talk for the second session is Dr. Alejandro Casalino from UCSF, who will be talking on patient-reported outcomes after surgical fixation of acute posterior SC physeal fractures and dislocations in children. So Dr. Casalino, will you kick us off?
Sounds good. Let's see. I'll share my screen here. Is that looking okay? So hi, my name is Alejandro Casalino, and I'm a first-year resident at UCSF. I'll be presenting on patient-reported outcomes following surgical fixation of acute posterior sternoclavicular physeal fractures and dislocations in children. MJ is a 15-year-old male presenting to the ED following a football injury with anterior chest and shoulder pain. X-ray and CT demonstrate an acute posterior sternoclavicular dislocation requiring surgery. With his goal of returning to football, MJ wanted to know how this injury would affect him in the long term. Acute sternoclavicular fractures and dislocations, or SCFDs, are a rare but important injury in pediatric patients. FCFDs are either true dislocations or, more commonly, physeal fractures in children, given the medial clavicular physis does not close until adulthood. Reduction is advised given the proximity to surrounding vascular structures, and some authors advocate for routine fixation given rates of redisplacement after closed reduction. The purpose of the current study was to provide validated long-term functional outcome data following open reduction and surgical fixation of pediatric SCFDs, as well as provide injury and demographic information. Surgical technique included an incision centered on the medial clavicle extending to the manubrium. Once exposed, the reduction was augmented with fiber wire suture fixation in a figure of 8 pattern. Retractors were placed to protect vital structures posterior to the reduction. 37 patients that sustained an acute posterior sternoclavicular fracture dislocation during the 30-year study period were included. In terms of demographic information, the average age at the time of injury was 15 and 89% were male. The surgeons determined that 81% had physeal fractures and the remainder sustained isolated dislocations. 87% of injuries occurred while the patients were participating in sports, with over half of these sports representing football and hockey, as seen here. 11% reported mediastinal symptoms, while all reported anterior chest and shoulder pain upon presentation. Most patients underwent a CT scan in order to evaluate for catastrophic events. The sites listed here were compressed by the fracture dislocations as seen on CT. However, with surgical reduction and fixation, no complications were observed. Patient-reported outcomes were obtained for 14 patients with a mean follow-up of 4.5 years. 29% of these patients stated that their injury negatively affected their ability to participate in sports. The average quick dash score was 5.1 out of 100, with 0 representing normal function and 100 representing the highest possible disability. In terms of quick dash responses, patients struggled most with pain, followed by recreational and social activities, washing their back, and household chores. No patient struggled to cut their food or open a jar. Mean PROMIS upper extremity questionnaire T-score was 55, with 50 being the mean for the relevant reference population. The mean visual analog scale, or VAS for pain score, was 0.7 out of 10. Mean single assessment numeric evaluation, or SANE score, of shoulder function was 96%, with 100% being completely normal and fully functioning. In conclusion, FCFDs are commonly occur in adolescent boys in the setting of sports injury, and the majority of these injuries are physeal fractures. Patients in the current study had overall good results with surgical fixation with minimal long-term disability. Given the rarity of these injuries, a longer-term multi-center study is suggested to further evaluate functional outcomes following these serious injuries. The importance of the current study is that it allows physicians to provide patients, such as MJ, with guidance and expectations for their recovery. MJ was eventually able to get back to playing quarterback for his high school football team and went on to be state champions. Thank you.
Thanks, Dr. Casalino. I'm glad you ended with a happy outcome. That's Thanks for doing that. So next speaker is Dr. Matthew Hsiao from UCSD, who will be talking about the association between rotator cuff tears and superior migration of the humeral head in rotator cuff arthropathy, an MRI-based anatomical study. So Dr. Hsiao, please take it away.
All right, thank you, Dr. Bernthal. Can everyone see my screen? Looks okay. All right.
Gotcha.
Perfect. I'm Matt Hsiao. I'm a orthopedic surgery resident at UC San Diego. I'll be talking about my study, which is the association of rotator cuff tears and superior migration of the humeral head and rotator cuff arthropathy. This was an MRI-based study. Superior humeral migration has been established as a component of rotator cuff arthropathy. The acromiohumeral interval is measured from radiographs and has been validated in previous studies. The thought is that it disrupts normal glenohumeral kinematics and is associated with more advanced disease. Prior studies were mostly based off of x-rays and ultrasound and maxed out at about 50 to 60 patients in terms of sample size. Currently, the data is mixed regarding the specific rotator cuff pathology that leads to or contributes most to humeral head migration. So our purpose was to determine the relationship between severity of rotator cuff tears and acromiohumeral interval via a large sample of shoulder MRIs. This was a retrospective cohort study where we reviewed 257 high quality 3T shoulder MRIs at our institution between 2010 and 2019. 3 orthopedic surgeons and 1 musculoskeletal radiologist measured AHI. The figure on the right shows how it was measured. Measurements were made on the coronal slice that demonstrated the shortest AHI. The measurements were made from subchondral bone plate of the humeral head to the cortical margin of the acromial undersurface. Rotator cuff pathologies were then recorded from imaging reports made by fellowship-trained musculoskeletal radiologists. Of 257 patients, about 77% had at least 1 rotator cuff tendon tear. About 2/3 of these patients had a supraspinatus tear, about half had an infraspinatus tear, about 1/3 had a subscapularis tear, and teres minors tears were rare. Full thickness tears of the supraspinatus, infraspinatus, and subscapularis were associated with decreased AHI compared to non-full thickness tears. This is shown in the graph below of the incidence of differing grades of rotator cuff tears. And as you can see, I don't know if you can see my cursor, but full thickness infraspinatus tears had the lowest AHI. Having a higher number of torn rotator cuff tendons was associated with decreased AHI. Moreover, isolated infraspinatus tears had the lowest AHI compared to isolated supraspinatus tears or a combination of supra and infra tears, although this last finding was not statistically significant. This is by far the largest study looking at superior humeral head migration, with prior studies, like I said, maxing out at about 50 to 60 patients and using X-ray or ultrasound. Although various rotator cuff tears have been associated with superior humeral head migration, our study demonstrates a correlation between any complete rotator cuff tear and superior migration of the humeral head. Of the rotator cuff tendon ruptures, the infraspinatus seems to have the greatest effect on maintaining the native position of the humeral head. Perhaps this is due to the broad footprint of the infraspinatus on the greater tuberosity and the vector of its force on the humeral head. However, further studies are needed to determine whether early surgical address, such as repair or a superior capsular reconstruction of these tears in the appropriate patient, of course, can slow the progression of rotator cuff arthropathy. Thank you to my co-authors and to OREF for hosting this conference.
Thanks for a great talk and really big series. So that's certainly a helpful contribution to the literature. The next speaker is Dr. Christopher Holland from the University of California, Davis, who is going to talk about the important issue of opioid use in revision total hip arthroplasty. Dr. Holland.
Thank you very much, Dr. Bernthal. Let me just start this presentation here. So I'm a PGY4 at UC Davis. I'm going to discuss opioid use in revision total hip arthroplasty experience that we have at our institution with this. Currently, a hot topic of research in the arthroplasty literature is opioid use in arthroplasty surgery, especially preoperative narcotic use. A recent article out of the Yellow Journal showed that preoperative narcotic use is one of the strongest risk factors for postoperative prolonged opioid use. And then a more recent article from the Journal of Arthroplasty showed that patients who have been diagnosed with opioid use disorder are at greater risk for implant-related complications, periprosthetic joint infections, readmissions, and actually have a higher cost of total hip arthroplasty in the primary setting. Given the paucity of literature surrounding revision total hip arthroplasty and opioid use, we wanted to analyze our experience with preoperative, perioperative, as well as postoperative opioid use in our surgeons' hands with revision arthroplasty. This was a retrospective review. We included patients who had undergone revision total hip arthroplasty at our institution from 2010 to 2018. We excluded any patients who had a repeat surgical intervention in the 24 months after their revision, any time points that lacked data for opioid prescriptions in our EMR, and then any patients that were lost to follow-up in those 24 months postoperatively. We then calculated the opioid use 3 months prior to the surgical event and then at various time points postoperatively, and this was all done using oral morphine milligram equivalents and then calculated. You can see here that we had 247 patients for our review over that 8-year time span. Patients were classified as opioid tolerant if they had the presence of an opioid prescription 3 months preoperatively, and we had roughly a 50-50 breakdown, 124 patients that were classified as tolerant, 123 naive. In our tolerant group, the average preoperative opioid use was 23.7 milligrams per day. Our tolerant patients were more likely to be active smokers, had higher ASA scores compared to our opioid naive patients. And interestingly, we did not find any significant difference in naive versus tolerant patients, specifically in patient age, surgical duration, indication for surgical revision, and then length of hospital stay after their revision arthroplasty. Interesting findings that we did have was that patients who underwent revision total hip arthroplasty and were classified as opioid tolerant actually required a significantly higher daily oral morphine milligram equivalency at the 3-month time point, the 6-month time point, the year, and the 2-year time point. And then we also found that after 6 months, patients in the opioid tolerant group were significantly more likely to require an opioid prescription than their naive counterparts in that study. In conclusion, patients who had an opioid prescription in our hands 90 days preceding their surgical intervention were more likely to require a narcotic prescription postoperatively and required more opioids in terms of daily usage than their naive counterparts. 80% of our naive patients were off of opioids at the 6-month time point versus 60% of our tolerant patients who actually required an opioid prescription 6 months after surgery. And as I mentioned, higher daily MME at all the postoperative time points and more likely to be chronic opioid users. So we feel that the astute clinician should be abreast of the fact that patients who do have preoperative opioid tolerance tend to develop a significant postoperative opioid dependence. I just want to thank our faculty who participated in this study, one of my co-residents, as well as the medical students who assisted us with this project. Thank you.
Thank you, Dr. Holland, and obviously critical issue moving forward. The Academy and is obviously very interested. So this is a important study. Moving to Dr. Shepard, Will Shepard from UCLA will be talking about lumbar sagittal mismatch deformity negatively affecting total knee arthroplasty outcomes. Professor Shepard, take it away.
All right, thanks, Dr. Bernthal. So I'm gonna just pull this up real quick. You guys able to see? All right, so my name is Will, I'm one of the PGY3s at UCLA, and I'll be talking to you about lumbar sagittal mismatch deformity and how it negatively affects total knee arthroplasty. There are no disclosures. So just to start off, a couple things about sagittal imbalance. One of two main ways to do it is you take a full length of the spine, you do a C7 plumb line, and you see where that lies in relation to the sacrum. The other way to do it is depicted here. It's called mismatch deformity. So to calculate the mismatch deformity, you need all 4 of those sagittal parameters. The pelvic incidence is one of the more important ones. It's the sacral slope plus the pelvic tilt. And when you take that into account to calculate your mismatch deformity, or MD, it's basically the absolute difference between the pelvic incidence and the lumbar lordosis. So if your value is greater than 10 degrees, you have sagittal imbalance in the form of mismatch deformity. So where does that come into play? If you look here, there's a couple of studies listed at the bottom, but basically the main point is in 2017, there was a big push for studies showing that there was a correlation between the hip and the back. They put that further and they looked at sagittal imbalance and how that can actually lead to erroneous cup position placement, dislocation risk, aseptic loosening, all types of bad things with total hip arthroplasty. And it also led to an increase in revision rates. So if you look at this video, thanks to JBJS, if it plays, you'll also see that when you go from a standing to a sitting position, you decrease your lumbar lordosis, you increase your pelvic tilt. Now in this image over here where my cursor is, A is representing a normal person standing straight up, B is someone with mismatched deformity, and you can see it's just standing, they've already decreased their lumbar lordosis and increased their pelvic tilt. So when they go to sit down, hence the issues that we see in the literature for total hip arthroplasty. Now where we come in is figure C. So you can see once you can no longer compensate based off of pelvic tilt lumbar lordosis, you start to flex the knees to bring the head back over the pelvis. There is no evidence that is showing any kind of relationship between mismatched deformity and total knee arthroplasty until 2020, recently out of our colleagues with NYU, noted that there was an association with stiffness. They saw that out of the manipulations of anesthesia that they were doing post-op from total knee arthroplasty, 60 to 70% of which had mismatched deformity. Outside of that, there's been no cohort study. There's no regression analysis, no mention of range of motion, arc of motion, flexion contracture, anything like that. So given this the deficit in the literature, we brought it upon ourselves to try and address these needs. So we retrospectively reviewed 933 total knees between 2017 and 2020, 5 different surgeons at our institution, and we ended up after exclusion with 94 total knees, 53 of which had mismatched deformity and 41 did not. As far as their characteristics from pre-op and demographics, there were no differences between the groups, but as expected, the sagittal parameters mentioned before were different, as well as every single one of our outcome measures, from manipulation under anesthesia, range of motion, arc of motion from pre to post-op, and flexion contracture. But we wanted to make sure that that wasn't confounded, so we did a bunch of different regression analyses. So the first one is actually in support of NYU's finding that if you have mismatched deformity, there is an increased risk of developing or needing manipulation under anesthesia. And just like Dr. Holland's paper touched on, there was also an increased propensity for opiate use. The next one we looked at was arc of motion, which was mismatched deformity decreased your arc of motion overall and decreased from preoperative to postoperative arc of motion, while increasing the risk of developing a flexion contracture. And there were no other variables that were contributing to these findings. Same thing with range of motion from 0 to 120. And we chose this parameter because 0 to 120 based off the literature is fully functional. 0 to 110 is the minimum needed to be able to participate in your activities of daily living. And mismatched deformity decrease your ability to meet this requirement. Now, as I mentioned before, we had 5 different surgeons, so we wanted to make sure we standardized things some way. So we looked at lucencies post-ops and the difference between materials used, and there were no difference between groups. So the most clinically relevant part of this talk is that 15% of those with MD actually required an MUA based off of our data, and that there was a 16-degree loss of the arc of motion if you had mismatched deformity. Furthermore, if you had mismatched deformity, 77% of the time you were not meeting the 0 to 120 range of motion requirement, and there was 23% of which developed a flexion contracture on average of 6.25 degrees, which is pretty significant. Most significant, however, is that there was a 5-degree reduction in the preoperative to postoperative arc of motion in those with mismatched deformity versus an actual increase or improvement in knee range of motion from 9.7 degree increase of your arc of motion if you did not have mismatched deformity. So we should definitely consider spine imaging or a spine evaluation in anyone that we're suspecting of having mismatched deformity, because we need to talk about these outcomes because it's the first time it's been described in the literature, and it seems to temper expectations in those with mismatched deformity. So thank you for your time, and this conference is awesome.
Thanks, Will. Great job. So we'll move to our next UCLA resident, Dr. Rishi Trika, who is going to talk about inhibition of angiotensin converting enzyme impairs anti-staphylococcal immune function in a preclinical model of implant infection. So Rishi, take it away.
Thank you so much, Dr. Bernthal, and thank you so much for this opportunity to present my work today. My name is Rishi Trika, and today I'll be discussing how angiotensin-converting enzyme inhibitors impaired immune function in a preclinical mouse model of implant infection. Here are disclosures. So angiotensin-converting enzyme inhibitors and angiotensin receptor blockers are two of the most widely utilized medications today. There's emerging evidence both in vitro and in short-term in vivo models that suggest an immunomodulatory effect of ACE inhibitors. So we sought to assess whether perioperative ACE inhibitor treatment altered the host immune response and affected infection rates and severity in our preclinical mouse model of implant infection. We first performed a series of ex vivo experiments after treating mice with either an ACE inhibitor, an ARB, or control for 4 weeks, 6 mice in each group. Here you see the results of our DHR assay, which looks at the respiratory burst activity of our conditioned mice blood. And you can think of this as an inherent antimicrobial function measure. And as you can see in the graph, the ACE inhibitor group had a significantly decreased respiratory burst activity as compared to both other groups with a p-value of less than 0.05. In a separate experiment, we added bacteria to our conditioned mice blood and ran a crystal bio assay to look at the residual biofilm ex vivo. And again, here we see that the ACE inhibitor group had a significantly higher bacterial burden ex vivo than both other groups. We then turned our attention in vivo, and one of our implant infection model utilizes a spinal implant that is press-fit into the L4 spinous process of a mouse and subsequently inoculated with Zen36 Staph aureus. And this strain of Staph aureus is particularly beneficial because it emits a bioluminescent signal. And through bioluminescent imaging, we can not only longitudinally track the infection, we can actually quantify the bacterial burden without having to sacrifice the animal. So on the bioluminescent curve seen on the left-hand side, overlaid on a logarithmic axis, you see that the ACE inhibitor group had a significantly higher bacterial burden at all time points other than postoperative day 3 and expectedly postoperative day 0. At postoperative day 28, we sacrificed the animal, harvested the implant, harvested the paraspinal tissue, and performed CFU data. And again, we see here that the ACE inhibitor group had a significantly higher bacterial burden in vivo. We then took this one extra mechanistic step and used an F480 and an MPO stain to find that monocyte and neutrophilic recruitment, respectively, were decreased in the ACE inhibitor group. Here we see a quantification of monocyte recruitment at postoperative day 1 and postoperative day 4, as well as qualitative imaging showing us the same thing. Similarly, by using an MPO stain to look at neutrophilic recruitment, we see the quantification at postoperative day 1 and postoperative day 4, as well as the qualitative histologic imaging. So in conclusion, we found ex vivo and in vivo evidence that suggested that ACE inhibition increased infectious burden via compromised immune effector cell recruitment and possibly function, specifically monocytes and neutrophils. Thus, ACE inhibitor treatment may represent an underappreciated and importantly, a modifiable perioperative infectious risk factor. When you consider in 2017, more than 28 million patients in the United States were prescribed an ACE inhibitor, and more than 17 million patients were prescribed an ARB, the clinical ramifications of this study could be pretty vast. Lastly, and most importantly, thank you to our entire lab team, who this would not be possible without. Thank you again for this opportunity to present today.
Thanks, Rishi. And for the last talk of this session, Dr. Matthew Churches from UCSF will be talking about complications after radial head replacement mid to long-term follow-up. Dr. Churches. Is Dr. Churches logged in here?
Hi, this is Sachin. I'm from UCSF. Matt Churches texted me saying he's having internet issues, and so I'm not sure when.
Yeah, so why don't we actually, that's okay. Let's move to a question and answer session for this group, and we'll tag him in and add one more talk to a later session. So this gets us, thank you, by the way, thanks for the update. So if all of the presenters from the last session could turn their cameras on, it looks like most of them have them. And then again, you can put questions into the chat room if possible. and I'm happy to read them, but I'll get things kicked off here. Maybe first to Dr. Casalino, who I hope is not driving, but someone else is driving that car. But Dr. Casalino, if you can give us a little bit on one of the challenges we always see with, it's a beautiful study you did, it's over a long period of time, and it's one of the challenges with any of these PRO studies that looks at a long period of time. It looks like you had PROMIS scores. How many of the patients had consistent PRO outcomes, and what were the challenges? How did you guys overcome sort of, we've been measuring PROs in different ways over the last several decades. And so how did you get through that with a study like this?
Yeah, so sorry, I'm just headed to clinical responsibilities right now in a lift, so apologize for that. But yeah, so it's definitely a huge challenge with these PRO type projects. The way that we collected the data was electronically, so we emailed out surveys periodically to the patients. And I think that's part of the reason that our patient-reported outcome portion of the study was so small. There's 14 out of the total patients, was that it's hard to get the patients to respond to the surveys. We tried also calling patients. So we would call patients in addition to email them to sort of encourage them to respond to the surveys. But it's definitely the biggest barrier in getting this sort of data, although I think it's incredibly important data and really impacts clinical care and the treatments that we offer patients. So I think although it takes a lot of effort, I think the effort is totally worth it.
Thank you. Couldn't agree more. I mean, one of the big challenges we have is how to capture these PROs. And so thank you for your effort. It's an important cohort to study. Dr. Xiao, really nice talk. And I guess one of the questions with humeral head migration coming from a tumor guy who does not do any rotator cuff surgery at all, so kind of at the lowest level, is I guess I think of this kind of humeral head migration issue as a longitudinal issue and not a static issue. And so how do you jive kind of taking a single time point MRI that shows a single cuff, or, you know, sort of captures one point in time? How do you kind of factor that into the overall process of humeral head migration and what happens over time?
Oh, that's a good question. You're totally right. It is a longitudinal thing. People are dealing with rotator cuff issues for decades before any kind of discussion, an SCR or, you know, some kind of arthroplasty in the shoulder. Yeah, and that is one of the limitations of our study. That's, you know, it's looking at one point in time where we're not excluding anyone based on their age or how long they've had shoulder pain, or, you know, everyone got these MRIs for different indications as well. And we're you know, we're very aware of that limitation, but I think overall our strategy was just, if you get the shoulder MRIs from a large cohort of patients, then you're kind of balancing out those patient populations so that you can kind of get a general assessment of the overall population that presents with shoulder pain and can kind of make inferences from there. But yeah, I agree, that is a hard thing to discern.
That's a really nice study, and given the sample size, it may mitigate some of those challenges. So great work. I look forward to seeing it in print. The next question, Dr. Holland, looking, given that your study looks between 2010 and 2018, I guess I'm wondering if, you know, a lot has changed in opioid usage, a lot has changed over that window. And is there anything you guys are doing differently at Davis about patient education or expectation? I mean, what do you think is the actionable next step, other than us being scared going into surgery on these folks who have used opioids?
Yeah, no, I think that's a great question. I think the one big thing that we've instituted, whether it's a revision surgery or primary, is enhanced recovery after surgery protocols. That's also a big push from the academy right now. So we're trying to really implement multimodal pain control. Surgical technique, as I would say, hasn't changed significantly, but I think slightly improved in the last 8 years over the study course. But one big thing is kind of addressing, one, what's the indication for surgery, and then what's the patient presenting for? Because oftentimes patients who are having revisions are presenting with pain as one of their symptoms. That may not be the indication for surgery, but that's what brings them back into clinic. Hip spine pathology is another reason why patients can be on chronic opioids. And I think as a kind of a clinic goal, we're trying to decrease the opioid usage, even if patients are not completely opioid naive before surgery, but we're trying to do something called prehabilitation, where they minimize their opioid narcotic usage leading up to surgery, or even try to take a holiday from that. So I think implementing multiple factors are helping to improve our outcomes in that regard. And then just to answer one of the questions in the chat, for calculation of the MME after patient discharge, that was one of our limitations. We just used all of the information we had in the electronic medical record. So if they had an e-script in or a paper script, that goes into our EMR, and then we calculated that under the assumption that if patient got a refill, they used all that previous prescription. So that's how we went more into detail on that.
Thank you. Great answer. And thanks for picking up on the chat question. That is, you're a savvy veteran to be able to take on 2 questions at one time. Nice work.
Thank you.
So, and also I would just implore you, as you make these changes, you've got great normative data right now. And so as you make changes in your protocol, even small sample size assessing changes would be really valuable to the rest of us to say what worked and what didn't. So please do keep us apprised of your progress.
Yeah, thank you.
Dr. Shepard, really nice study. You made a topic that makes very little sense to most of us make sense with the diagrams and the pictures. So thank you. It's always a complicated concept. And I guess what I'm wondering about is, okay, you have this patient who is the typical geriatric patient who has a spine problem and has a hip or knee problem. Do you have any wisdom for us on what order to tackle these problems, and would we mitigate these challenges if we did the spine before the joint? How does that work?
So that's actually a hot topic. We have several other presentations or possible projects that are coming out right now, looking at stenosis, looking at spondylolisthesis, all types of different things that are happening concomitantly to kind of answer this question. So I don't have the definitive answer to you, but we're all thinking that a prospective trial needs to happen. So what we're hoping is that we take all of this retrospective data, collect it, submit an IRB, get an EOS machine for full spine imaging, and then anyone who comes into the joints clinic with back pain who we suspect might have a little bit of mismatched deformity, we send to get an X-ray, and then we basically prospectively follow them to get this answer. Some studies, there's a couple in the spine literature that are mentioning that you should do the spine first. There's a couple in the joints literature that are saying you should do the joints first. And obviously I've worded it that way because you can see there's a little bias. So I think we don't quite have the answer, but the answer is coming.
Great, thank you. Dr. Trika, you got to finish us off with, one of the big challenges in this world is you do a beautiful mechanistic study in mice, and you have some people who are going to react to that and say, that works great in mice, but my patients are a lot more complicated. So what are the steps to take your findings and move to something that becomes standard of care, potentially switching patients from ACE inhibitors to ARBs prior to surgery? What do you think we should do should we just do it today? Do you trust your data enough, or what do we do between here and there?
Yeah, there's certainly translational limitations with any animal model. I think the next obvious steps, retrospective studies, randomized clinical trials, and going through that route. There's also a fair bit of ongoing clinical trials trying to get mechanistic ex vivo with patients' blood currently. So that's another avenue for continuation, certainly. But yeah, agreed. The translational models and limitations, rather, of any animal model are well received.
So what's your next step?
My next step is a retrospective clinical study that we're doing here at UCLA. And so we'll see.
Got it. Thank you. All right. Well, we're right on time. I had the advantage of one person having technical problems. So, but a great job to the group here. Great talks and very professionally given, and great job with the extended Q&A session. So thank you all. And we'll turn it over to Dr. Adam Lee, who's going to moderate the third session.
Good morning, everyone. Thanks for having me. We'll move straight to it to stay on time. We'll dialogue a bit in the Q&A session once we get there. So I will turn the screen over to Dr. Gailey.
Great, thank you, Dr. Lee. Let me see if I can get my screen going here. Okay. Hello, everyone. I'm Scott Gailey. I'm a fourth-year orthopedic resident at UCLA. This study is entitled Compressive Osseointegration for the Management of Non-Oncologic Salvage Arthroplasty. I'd like to thank the Orthopedic Research and Education Foundation for the opportunity to present here today. But to get started, compliant pre-stress or CPS systems, more commonly known as compress implants, have been traditionally used as an alternative to intramedullary implant fixation in orthopedic oncologic limb salvage settings. These implants exert compressive stresses at the bone implant interface to induce bony hypertrophy and achieve implant fixation in a relatively short segment of bone. These implant systems also have applications in complex revision or deformity arthroplasty, where bone stock may be compromised or try to be preserved. While the CPS system has a more proven track record in the oncologic limb salvage population, few studies or groups have investigated the application of this implant system in the non-oncologic or revision arthroplasty setting. Our purpose in this study is to present our short to medium term outcomes of a series of 66 system implantations, CPS system implantations in both the total hip and total knee revision arthroplasty setting over a period of 15 years. So between 2004 and December 2019, 66 revision or complex primary total knee and hip arthroplasty procedures using a CPS implant were performed by 3 arthroplasty surgeons. This cohort was reviewed retrospectively. Outcome measures included implant failures, complications, and outcome scores, including knee society scores and Harris hip scores. A Kaplan-Meier spiral analysis was performed. The demographics are shown. Overall, we had 44 revision TKAs in 40 patients and 21 revision THAs and 1 complex primary THA in 20 patients that were reviewed. Throughout the course of the study, 6 patients had passed away, with 4 having well-fixed implants at the time of death. The mean age in our cohort was 61 years, and the mean follow-up was 2.3 years. Important to note that 44 of the 66 implants were placed in patients with previous diagnosis of PJI, and overall, our patients in our cohort had an average of 5.9 previous procedures on the affected and studied joint. The survivorship at final follow-up was 53%. There were 31 or 47% implant failures requiring revision, including 13 periprosthetic fractures, 11 infections, and 7 instances of mechanical loosening. The mean time to failure was 1.2 years. There was a trend towards a higher rate of failure in those with a previous diagnosis of PJI. Of the surviving implants, knee society scores and Harris hip scores improved 28 and 26 points respectively. There was no association found between failure and BMI, diabetes, smoking, age, gender, or previous infection. The Kaplan-Meier survival curve is as shown. On the left, we show the curve for the survival of the entire group. On the right, the survival curves have been stratified by previous infection history in the studied joint. The trend towards a higher failure rate in those with a previous diagnosis is again seen. The previous infection is in red and the non-infected are in blue.
So in conclusion, we observed a high rate of failure of the CPS implant in this patient cohort. It is important to note that this was a high-risk cohort with multiple previous failed limb salvage procedures, and almost 2/3 of the patient in this study were previously diagnosed with a prosthetic infection. Our periprosthetic fracture rate was almost 20%, which is notably higher than previous studies of the CPS implant in the oncologic population. The authors of the study postulate that the high rate of fractures in this group is likely due to multiple factors that weaken the host bone in this group, including previous cement implantation and extrication, possible ongoing infection, and advanced patient age. In terms of limitations, there are several. First are the limitations inherent to an uncontrolled retrospective review. We also had a limited period of follow-up at just over 2 years. However, the high failure rate demonstrated that even this limited follow-up, I think, is notable. Additionally, our study was underpowered to determine the relationship between age and failure rate, limiting our ability to support hypothesis that this implant choice may be more susceptible to failure due to the age and osteoporotic status of more elderly bone. Overall, we suggest that surgeons exercise caution with the CPS system in the elderly multiply revised arthroplasty patient, given the high failure rate of the device in this patient cohort. I'd like to thank you all for your attention, and of course, my co-authors and collaborators for their help on this project. Thank you.
Nicely done. We will move on then for Dr. Alahabdi.
All right, good morning. You guys can see my screen?
Yes.
Thank you. All right, I'm Sachin Alahabdi. I'm one of the residents at UCSF, and I'm going to be presenting on behalf of our group on a large closed cohort study evaluating risk factors for conversion of hip arthroscopy to total hip arthroplasty. These are my co-authors. I'd like to thank them for their support, and we have no disclosures to report. So the ultimate goal of hip arthroscopy in managing femoroacetabular impingement is to improve hip function and longevity and serve as a joint preservation procedure. There's been a rapid increase in hip arthroscopy in the United States, and it's been shown that the most common indication of hip arthroscopy is FAI, with or without labral tear. It is important to note that all types of hip impingement have been associated with the development of osteoarthritis, and the failure of treatment has been defined previously as a progression to arthritis after hip arthroscopy or conversion to total hip arthroplasty. Understanding the risks of these failures can help guide surgical indications. Therefore, we developed we evaluated a closed cohort in the Kaiser Permanente system to evaluate for risk factors for conversion to total hip arthroplasty after hip arthroscopy within 2 years, and hypothesized that older age, increased BMI, and prior hip arthroscopy all would increase risk. This was a retrospective study between 2008 and 2018, and the primary endpoint was conversion within 2 years. We included all patients who had hip arthroscopy with or without labral repair with required minimum 2-year follow-up. However, if a patient had conversion within 2 years but had less than 2-year follow-up, they were still included. And as you can see here, the majority of our diagnoses were for FAI, labral tear, or both. In total, we included 1,561 total procedures of hip arthroscopy. Our median follow-up was 4.6 years, and the median time to conversion was 9 months after arthroscopy. And notably, in the total hip arthroplasty conversion group, they were of a greater age, higher body mass index, had a different proportion of races with a higher proportion of whites, and a higher incidence of prior ipsilateral hip arthroscopy. When evaluating these factors on a multivariable analysis, we noted that the BMI and prior arthroscopy and age were all significantly associated with conversion. However, when you look at these factors on the receiver operating curve, we found that the area under the receiver operating curve, including just age, was 0.78, which is significant. And when you add in the other factors, the area under the curve only increases to 0.79, and this was not statistically significant, showing that age was the most meaningful predictor to conversion. As you can see here, in this chart, you have different deciles of age groups, and with increasing age, there was an increased conversion rate. So ultimately, as mentioned, increasing age was most predictive of conversion to total hip arthroplasty within 2 years of hip arthroscopy. One of the strengths of this study is that it's a closed cohort system. So in the Kaiser Permanente network, patients are more likely to be captured for conversions and their subsequent procedures because of the style of the healthcare system, therefore providing a more accurate rate of conversion. We defined total hip arthroplasty as a failure, which is a repeatable and reliable outcome measure. And when we evaluated the contribution to the area under the curve of the receiver operating characteristic, although BMI and prior arthroscopy were statistically significant, they did not add any meaningful predictive value to the area under the curve, which was different from some prior studies in more open cohorts, which have identified BMI, sex, and prior arthroscopy as predictive of failure. Future directions, and one of the limitations of studies that we did not evaluate the impact of degenerative changes independent of age. So what, preoperative or radiographic osteoarthritis was not considered, which could influence things independent of patient age. Thank you for your time.
Thank you, sir. Moving on to Dr. Mitchell, if you could queue up your presentation, please.
Awesome, thank you. Can you guys see?
Yes.
Perfect. All right, so good morning. My name is Brendan Mitchell and I'm a PGY3 resident out of UCSD. Today I will be presenting a study performed at Rady Children's Hospital assessing outcomes in adolescent multidirectional shoulder instability, or MDI, patients treated with arthroscopic capsular repair using suture anchors. MDI is a complex shoulder disorder that can be challenging to diagnose, manage, and treat. Certain demographic factors such as female, sex, and younger age have been shown to influence the incidence and severity of presentation. At present, arthroscopic capsular repair is the preferred technique for the treatment of MDI, the MDI patient who fails conservative treatment, with reported failure rates defined as recurrent instability ranging from 8 to 31%, and a pre-op return to level of sport rate of 50 to 86%, with typically good functional outcomes. However, this data is derived mainly from an adult patient population. Prior literature has summarized outcomes in adolescent athletes treated with arthroscopic capsular repair for unidirectional instability, as demonstrated in the tables above, with posterior instability on the top left and anterior instability on the right. The purpose of this study was to specifically evaluate MDI in the adolescent patient population to determine if there was an overall benefit from surgical intervention that was comparable to the adult population and to adolescent athletes treated with unidirectional shoulder instability. So we performed a retrospective single center, single surgeon review of patients treated surgically for MDI. Adequate capsular repair was confirmed by an absence of the drive-through sign prior to portal closure, as shown in the bottom right. Outcome measures consisted of single assessment, numerical evaluation, pediatric and adolescent shoulder survey, and the short version of the disabilities of the arm, shoulder, and hand survey. Surgical failure was defined as any patient experiencing recurrent postoperative instability. The figure above demonstrates a representative case. A glenolateral articular disruption lesion is seen with an intact anterior inferior labrum and posterior labrum, both viewed from a superior position. Plication of the capsule is performed from inferior to superior, as demonstrated by the arrows, to perform an antero-inferior and posterior-inferior capsulorrhaphy via placement of anchors, demonstrated with the stars within the glenoid. 80 adolescents, or 88 shoulders, were identified for having undergone surgical treatment of MDI. Of these 80 patients, 50 shoulders, were available at minimum of 2-year follow-up. Mean follow-up was 6.3 years. A comparison of sex was performed, given that adult literature has shown differences in pathology and outcomes in these two cohorts. Patients received a mean of 1.9 posterior anchors, 1.6 anterior anchors, and 3.5 total anchors. There was a statistically significant difference in total anchors used, with more anchors needed in males. Capacious capsule was noted in 68% of cases with a predilection toward female sex. Labral tear was noted in 70% of cases with a predilection towards male sex. 26% of shoulders experienced surgical failure defined by recurrence of subluxation instability, all of which required reoperation. Time to reoperation occurred at a mean of 1.9 years with a range of 0.8 to 2.9 years after index surgery. Return to prior level of sport occurred in 56% of patients. None of the patient characteristics, including age and sex or arthroscopic pathology, were correlated with subjective outcomes or reoperation. There was no statistically significant difference in the number of anchors for patients who experienced surgical failure compared with those that did not experience surgical failure. A survivorship curve was generated to demonstrate overall survivorship of 96% at 1 year after surgery and 76% at 3 years. The limitations of our study relate to the retrospective study design, yet we still had a mean of greater than 6 years of outcomes to evaluate and compare for prognostic factors. Regarding the diagnosis of MDI, we decided to use strict criteria, and as such, it was possible that we excluded patients with only partial findings consistent with MDI. Despite our limitations, we feel the data presented provides a valuable summary of the outcomes after surgical intervention in a typically understudied population. In conclusion, multidirectional shoulder instability is a complex disorder with historically poor outcomes in adult patients when treated non-operatively. However, we show that adolescent MDI patients refractory to non-surgical management have midterm failure rates after surgical intervention that are comparable to patients with unidirectional instability of the same age group. In adolescents who do experience surgical failure, our case series shows that failure will most likely occur within 3 years of index surgical treatment. There is a clear distinction in associated pathology between sexes. However, associated pathology at presentation and number of anchors, representative of perceived extent of capacious capsule used, do not appear to correlate with outcomes. In adolescent athletes with MDI that is refractory to conservative management, surgeons should continue to utilize capsulolabral repair to enhance surgical stability. However, it is important to counsel families and patients undergoing the procedure that functional outcomes are likely to remain high, even if return to prior level of sport participation may not occur. Thank you for your time.
Thank you, sir. We'll pass the mic to Dr. Chin.
Good morning, everybody. I'm in our clinic, so I'm asking protocol here, but I'll be giving a talk about titled "Does conflict of interest affect the reported fusion rates with bone graft extenders?" Just some quick background. Spine is the third most common orthopedic specialty, with authors declaring a financial conflict of interest. And it's well known that industry-funded studies are more likely to report favorable results. And funding source and conflict of interest have caused bias and underreporting of unfavorable outcomes, which have ultimately led to poor outcomes in spine surgery for some patients. What we did was we conducted a PubMed search for studies evaluating fusion rates when bone graft extenders were used, including demineralized bone matrix, hydroxyapatite, and tricalcium sulfate. The studies were screened for 1 or 2 level fusions, or specifically for degenerative spinal conditions. We found 1,928. Actually, let me put this in presenter mode. Sorry, everybody. We found 1,928 studies, and after screening, 86 studies were included in this study. Of those 86 studies, the average sample size was 56.9 patients. The average follow-up duration was 16.8 months, and the average fusion rate overall was 84.6%. We then delineated the data into different groups based on whether or not they had conflict of interest, used CT scans to evaluate their fusions, or had independent reviewers to evaluate their fusions, and calculated the average fusion rate for those groups. Here listed are the number of studies that fit those different criteria, and the fusion rates of those groups are listed in parentheses. Again, the overall fusion rate was 84.6%, and the fusion rate for groups with conflict of interest was actually 5.2% lower than the group without conflict of interest, which based on historical studies into this subject was unexpected. However, this was not statistically significant. We then compared studies with and without CT scans for evaluation of fusion, and found that those studies with CT scans had an 8.1% lower fusion rate than those without CT scans, and this was statistically significant. And when comparing studies with and without independent reviewers, those studies with independent reviewers had a 3% lower rate of fusion, which was not statistically significant. When comparing studies with no conflict of interest that also had a CT scan to those with no conflict of interest but no CT scans, the fusion rate of those that use CT scans were 8% lower than those without CT scans, and this was statistically significant. There was insufficient data to run a similar comparison between studies with conflict of interest. These findings were unexpected because studies with conflict of interest actually had a lower rate of fusion than studies without conflict of interest, which is not what any of us would have expected. And they're interesting because it was actually the studies using CT scans and independent reviewers that had lower rates of fusion, which we think suggests that these measures may be more stringent tests for evaluating fusions. And although the economics of research have led to an increased reliance on industry support for the advancement of spine research, CT scans and independent reviewers may represent an effective strategy to control for this conflict of interest while still advancing research in spine. Thank you very much.
Thank you. Dr. Shaw, if you could queue up your presentation, please.
Sure thing. Let's see. All right. Let me know if there's any issues hearing me or seeing the screen. So good morning, everyone. My name's Akash Shah. I'm a resident at UCLA Department of Orthopedic Surgery, and I'm going to talk to you guys this morning about an externally validated machine learning algorithm that predicts 90-day and 1-year mortality after surgery for spinal mets. So the spinal column is the most common site of bony metastasis, and the incidence of spine mets is expected to grow, as is the incidence of surgery for this condition. And surgery is typically performed to alleviate pain, instability, or neurologic compromise, but of course, this doesn't come without risk. Patients with metastatic disease are sicker, they're immunosuppressed, and so they're less likely to rebound from postoperative complications. And so when we're weighing the benefits of surgery against the risk of complications, patient survival is a critical consideration. And yet we're notoriously bad as physicians at accurately predicting survival. Multiple scoring systems and calculators exist across specialties to estimate survival probability at different time points, and these are largely inconsistent. So we're part of the Skeletal Oncology Research Group, or SORG, initially based out of the Massachusetts General Hospital, and we developed these machine learning-based algorithms to preoperatively predict risk of 90-day and 1-year mortality in patients undergoing surgery for spine mets. And these have been shown to perform quite well and are internally valid. But while most existing algorithms for mortality have employed multivariable logistic regression, we've employed more advanced machine learning methods, so primarily boosting classifiers, to allow for detection of nonlinear relationships, as well as critically interactions between factors that traditional techniques would fail to capture. So our aim was to evaluate the performance of these algorithms using an independent, geographically distinct cohort based out of UCLA to assess their external validity and thereby determine their generalizability. So we had 298 patients with spine mets treated surgically between 2004 and 2020. And our primary outcomes, of course, were vital status at 90 days post-op and 1 year post-op. The explanatory variables that we collected were those that were used in the original algorithms. So tumor histology, preoperative performance status, preoperative neurologic status, medical comorbidities, and preoperative lab values. And then these algorithms were then tested on the validation cohort and assessed using discrimination, calibration, as well as just overall model performance. So of these 298 patients, 212, so over 70%, were treated in the last 10 years, and over 40% were treated in the last 5 years. 22% of patients died within 90 days, and 53% died within a year. And as you can see, these algorithms performed excellently. The area under the curve for 90-day mortality is 0.84, and it was 0.9 for 1 year mortality. You can kind of see the decision curve analysis here as well. So the mean survival in the literature for patients who present with spine mets is 10 months. And so accurately predicting both short-term and long-term survival is of great utility. And unlike prior risk tools and nomograms that provide a score and recommend treatment based on a total point value, our algorithms assess the relative contribution of each risk factor and then provide a patient-specific probability of mortality. And this would be incredibly useful in real time. So you can see that actually clearly here, right? These are screenshots of an app that we built with these algorithms, showing the feature input screen for all the explanatory features and a very clear output screen. And so with a cohort of 298 patients, we've successfully externally validated the SORG machine learning algorithms. These algorithms show excellent discrimination, they're well calibrated, and critically, this study was performed on a more contemporary cohort and is a geographically distinct population from the Boston-based derivation cohort that only goes up to 2016. And this is important for the generalizability of these algorithms, since the aim clearly is to apply them to present day and future patients across heterogeneous regions. And just in terms of kind of future work that we're working on now, those efforts would include international validation, retraining the algorithms with data from multiple institutions, as well as trying to get prospective studies lined up. Thank you all for your time.
Thank you, sir. Nicely done. And for the last, but certainly not least in the section, Dr. Hsu. There we go. All right.
Good morning, everyone. Today I'll be presenting the effect of hepatitis C infection on shoulder arthroplasty complication rates in U.S. veterans. These are our disclosures, none of which are relevant to this talk. Hepatitis C affects approximately 1.3% of Americans. Prior studies have demonstrated that hepatitis C increases the risk of one-year medical and surgical complications after total joint arthroplasty. Hepatitis C was previously considered a non-modifiable risk factor due to low cure rates. However, in 2014, the first direct-acting antiviral therapy became available for the treatment of hepatitis C with cure rates greater than 90%. One study today has shown that the preoperative treatment was associated with lower implant infection rates among U.S. veterans undergoing total joint arthroplasty. Thus, the purpose of our study was to determine if hepatitis C is associated with increased complication rates after total shoulder and to determine if preoperative treatments changes that risk. We hypothesized that hepatitis C would be associated with a higher complication rate and that treatment will decrease that risk. We performed a search of the VA database from 2014 to 2018 to identify a cohort of patients who underwent total shoulder arthroplasty. These patients were further divided into patients with and without hepatitis C using ICD codes and laboratory values. Hepatitis C patients were subsequently classified as treated if they received a directing antiviral during this time period. ICD 9 and 10 codes were utilized to identify the 90-day and one-year complication rates. The primary complication of interest was implant infection. Standard statistical analysis was used. 5,418 patients were identified. 9.8% of them had hepatitis C, 23% of whom were treated preoperatively. Patients with hepatitis C were more likely to be younger, have a concomitant diagnosis of HIV and hepatitis B, smoke, and have a higher Charlson comorbidity score. With regard to the 90-day complication rates, there was no difference in the medical or surgical complications between patients with and without hepatitis C. Similarly, there was no difference between treated and untreated groups. However, at 1 year, patients with hepatitis C had an increased odds of developing medical complications. This was driven by an increased odds of developing MI, pneumonia, sepsis, and AKI. Hepatitis C infection was not associated with an increased odds of developing a surgical complication, and there was no difference in complication between treated and untreated groups. On multivariate analysis, hepatitis C patients had a 1.4-fold increased odds of developing a medical but not surgical complication. There was no difference in complication rate between treated and untreated groups. Our study shows that the prevalence of hepatitis C in US veterans undergoing total shoulder is 10%, which is much higher than the national average of 7%. US veterans with hepatitis C are at an increased risk of medical but not surgical complications. Hepatitis C treatment does not decrease the implant infection rates in total shoulder. And our findings are consistent with the Medicare database study that showed that hepatitis C increased the odds of medical complications by 1.3 after total shoulder. However, they also reported an increased risk of surgical complications, including implant infection. There are several limitations to our study. As with any database study, the data is dependent on coding accuracy. Additionally, the effect of hepatitis C on the outcomes of total shoulder is multifactorial and perhaps should be viewed more as a medical complexity leading to increased complications rather than a standalone risk factor. Furthermore, the sample size of our treated patients may have been too small to detect a difference between treated and untreated populations. These are my co-authors. Thank you.
All right. Thank you all. If we could stop the screen share and queue up each other in these video formats. We're going to go backwards just to mix it up a bit with our most recent speaker, Dr. Hsu. You mentioned power to address the issue, or sorry, you mentioned power is one of the issues. One, how would you address it? And two, do you think it matters? It looked like the infection rate was pretty similar and you had hundreds of patients in both groups. That is, how much of a difference in surgical complication rates would you look for to determine significance, and how would you address it?
So in our analysis, we had 124 treated patients and about 400 untreated patients. The prior studies that have in the total in the lower extremity arthroplasty literature, there were about 400 treated patients, so about 4 times as much patients who were treated compared to our cohort. In that study, they did demonstrate both a 90-day and a 1-year increased implant infection rate difference between the treated and untreated groups. So one thing that could lead to this difference is that the total joints, they're performed much more frequently. And then there was a longer collection period, whereas with the shoulder arthroplasties, the follow-up data wasn't that long.
Fair. So I think what I'm hearing is that you would extend the collection period potentially, and maybe broaden the database, since it's not as prevalent a procedure as our total hips and total knees.
Yeah,
makes sense. Thank you all for your presentations, by the way. Rather well polished, and I was expecting to have to recover some time, but everybody was pretty much spot on. So Dr. Shaw, not familiar with these development and scoring of these machined algorithms, but I think it looks like it's a utility that will be useful in the management of these complicated patients. Do you think, and maybe you mentioned it, but I want you to address specifically, do you think the score helps to predict who actually should get the surgery? That is, aside from predicting mortality rates in a really accurate way, what is the utility of the score? That is, how are your colleagues using it to direct patient care?
So, I think one of the weaknesses of kind of current scoring systems is when they try to kind of enter into the kind of the space of trying to tell physicians how they should be acting. And, and I think that ultimately, whenever we make a determination, right, as to whether we're going to move forward with surgery or not, or do a particular treatment or not, we're trying to basically we're trying to balance the risks versus the benefits, right? And all we're trying to do is to create a tool that can more accurately give you a representation of the probability of a particular risk. Whereas before, someone might base their idea of risk off of personal experience, that has utility. But what if we could take the personal experience of 10,000 surgeons and basically use that to end up coming up with an idea of what the risk actually is, and then then we give a numerical probability, and then the decision to move forward with a particular treatment or not is a pretty complex one, right? So for example, if you were to have a 30% mortality rate in someone, say, in 90 days or something, and they're 80-something years old, perhaps you'd think a little bit differently versus if they were 25 years old. These are all very kind of complex decisions that require a fair amount of talk with patients and their families, and a lot of psychosocial sort of considerations. It's just that if these are difficult decisions, and if we could just provide a more accurate tool to base those conversations off of, I think that's actually really quite useful. And so that's basically what we're trying to do. We're not trying to to take over decision making. We're not trying to automate what physicians or surgeons have to do. We're just saying that the decision that you're going to make, base it off of better data than we currently base it off of.
Got it. Well said. Thank you. Dr. Chin, if you are a spine surgeon at some point in your future practice and you design a graft extender and want to objectively study it, how would you design the study to not become one of the statistics in your particular study?
Sorry, just navigating the clinic space here. I think the most important thing now is not even, it seems like conflict of interest or whatever the funding is doesn't even matter. It's just the stringency of the test. And the CT scans and the independent review showed a significantly lower fusion rate. So I think just having whatever stringent objective imaging you can you have available for the evaluation of infusion is probably the best test and kind of overrides whatever disagreement you may have about any funding sources.
Agreed. All right. Dr. Mitchell, my question for you is, it sounds like, again, this is about as far from any types of surgery that I do, so would not consider myself an expert, more of an amateur for sure. But a 26% failure rate with only 56% return to sport seems like pretty dismal numbers. So my question is there utility in waiting? That is, until they stop growing. I couldn't find anything in my brief look after I read the abstract, but with the failure rate that high and, you know, a quarter of the patients needing something else within 3 years, should we just be telling these kids that say, hey, this is a bad problem, maybe sports aren't your thing?
Yeah, it's a great question. And it's something that I think a lot of pediatric orthopedic sports surgeons kind of tackle with. And one of the things to consider is that, you know, a lot of these adolescent athletes, telling them to quit participating in a sport that they're participating in, specifically things like gymnastics, swimming, really hard to do. And oftentimes they won't listen. So I think that's one thing to consider. I think the other thing to consider is that the failure rates in adults remains really high. So that failure rate has been quoted at 8 to 31%. So it's definitely within the same realm of failure rate as seen in adults. And the other thing is that we actually collected return to prior level of sport. So our return to prior level of sport is a low number at 56%. But I would say that many of these patients still returned to some level of function and ability to participate. It just was not the prior level of sport.
All right. That helps to clarify it a bit for me. It's a problem I'm glad I did not have growing up. I'm going to steal the question from Dr. Suhu for our next respondent. So he's saying that there seems to be fairly short times to conversion. And he's asking, would you think the older age is a relative contraindication to arthroscopy at this point? And that kind of correlates with the question I was going to ask. That is, if you were going to pick an age where you say, hey, maybe we should just do arthroplasty and skip the whole scope part. Did you guys come up with a cutoff, or are you postulating? Would this change your practice? Say, okay, you're 47, you know what, let's just do a total hip.
Yeah, I think that's a great question. So the question is like, you know, the utility of age as a contraindication, or if there's a cutoff age for which hip arthroscopy may not be as useful. I think the real big question, and you know, like in our study, the total cohort rate of conversion was 5.3%. And if you look at those who, if you isolate that to just those over age 50, it's 15%, and over age 60 was almost 18%. So there's definitely a trend to higher likelihood of conversion with increasing age. You know, there's some other studies that have been done trying to evaluate whether age and degenerative changes are really independent. There's one study that was done in 2016 in which they evaluated radiographic changes, and they were able to find that patients with I think it was Kellgren-Lawrence grade 3 or joint space narrowing less than 2 millimeters was a risk factor for failure. And there's one study in New York that was done that evaluated patients, and in that study it was age greater than 60 years and was an independent risk factor of pre-existing arthritis. So I think, you know, if I have to give one age, I would say, you know, most studies are showing that over age 60 would be the age, but I think, you know, like anything else, and, you know, I think a good analogy is rotator cuff tears. You know, there's a difference between physiologic age and chronologic age, and really understanding where the patient is in terms of their degenerative changes that may be pre-existing that would increase their risk of conversion, but also just good patient counseling and saying, you know, hey, we can try this. You know, it could work, it could help, or it can at least buy you, you know, a certain amount of time. And depending on the patient, that may or may not be worth it to undergo a hip arthroscopy procedure, knowing that there might be a total hip down the road regardless.
Sure. and my question would be, and I won't press you to answer it, but we'll put it out into the ether. Does having a scope pre-hip predispose problems with the hip? That is, does it make the hip more complicated, increased risk of infection? I don't think we know that yet, but that would be the question that I have looming in my mind. Thank you for your thoughtful response. And last but certainly not least, Dr. Gailey, so you mentioned that the fracture rate is higher compared to the tumor in terms of failure rate. What I don't know, and at least I didn't catch it in the presentation if it was there, how do the overall complication rates compare to tumor? One, are they about the same, or are they worse with the arthroplasty conversions? And the corollary to that is, what's the alternative? So if you can't do a long stem and compress has this dismal complication rate, what's the other option? Are there other options?
Yeah, so I think that for sure fracture rate was higher in our group, and I think pretty much all other complications were as well. Looking at the compress implant, it's typically placed in younger oncologic limb salvage patients, so people who are 16 to 25 with some sort of primary oncologic issue that needs to be resected and reconstructed. The nice thing is, even though they have pre-op radiation, they're still young and their bone is likely more robust and biologically active than elderly, multiply revised arthroplasty patient bone. So I think that's why in general they have better survivorship and lower complication rates in that patient population compared to ours. Our patients are just older and that bone has been insulted both from the endosteal side and periosteal side multiple times. So I don't think it has the robust hypertrophy ability that is necessary for long-term stability of these implants. I think it's important that I mentioned that one of the strategic deployments of the compress implant is, you only have a short segment of bone. However, the senior author who did a majority of these procedures would sometimes do it even though there was bone that could accommodate a longer stem. So yeah, if you're in the situation where you only have a very short segment of bone, it's a coin flip based on our data whether or not it's going to work in the short term, medium to short term. However, you can always go to entire femur or tibial endoprosthesis, even though those obviously have their own complications and issues. So I think if our study, we'd like to go back and kind of better characterize how much bone was actually left and how many of the patients we studied actually could have supported an intramedullary stem, because I think not all of them were truly at the end of their rope. And it was more so one of the attending surgeons was excited about this implant, thought it had a lot of potential for his patients to preserve bone stock more so than that was his last option.
Sure. And I think if I get to 75 and I'm multiply revised, I might just say, take it all and don't put a small compact car worth of cost inside of my knee that's got a 50% failure rate, but that's just me. Thank you to the panel and to the presenters. I'll turn it over to Dr. Chu, who looked like he's chimed in and has something to say.
Yeah, great job, everybody. I think we probably should go ahead and take a 10-minute break at this point. So I think we'll return at 10:10 with Dr. Lin starting session 4, and Dr. Churches will kick that off for us. Actually, his tech is taken care of. So why don't we reconvene at 10:10. Hi, Dr. Lin, shall we get started with the next session?
Are we working on video or should I just continue?
Are you guys able to hear me?
Yeah.
Yes.
Okay. Sorry about the technical difficulties. One of my co-residents, Sachin, is actually going to share my slides for me, and I'm going to go through audio. So I'm Matt Churches. I'm a current PGY2 at UCSF, and I'll be talking about a project that we've done on complications after radial head replacement, looking at mid to long-term follow-up. So a little bit of background information, if you don't mind advancing the slide, Sachin. Radial head arthroplasty remains the preferred treatment for displaced radial head that are not that do not accommodate open reduction internal fixation. And while good short-term results have been reported, there seems to be a bit of a lack in the literature currently as to the mid to long-term radiographic complications, most notably loosening, stress shielding, and radiocapitellar arthritis, which are not uncommonly seen in the short term, in the long term. So the aim of this study was to analyze and both analyze and quantify the radiographic complications following radial head arthroplasty, specifically focusing on the mid to long-term follow-up of these patients. We hypothesized that there would be a high rate of radiographic stress shielding and radiographic capitellar arthritis that could be appreciated as early as midterm follow-up at approximately 6 months. So moving on to the methods, this was a retrospective study that was performed on patients who underwent radial head arthroplasty between 2006 and 2019 at 2 academic centers in San Francisco. Only adult participants with at least 6 months of radiographic follow-up were included in the study, and associated injuries around the elbow, fracture pattern using the Mason classification system, as well as implant design and radiolucency, stress shielding, and radiocapitellar arthritis were information was included. We also looked at heterotopic ossification about the elbow. And this was done using 2 teams consisting of 1 fellowship-trained orthopedic trauma or hand surgeon and 1 orthopedic surgery resident, with the average score between the 2 teams being used for the final analysis. Lastly, an age and gender controlled multivariable analysis was used to assess the relationship between Mason classification, implant type, and follow-up duration on post-operative radiographic complications, and then a multivariable demographics, follow-up duration, implant type, and injury severity, as well as stress shielding and radiolucency on the odds that these patients would have to go re-operation. Some of just bits of the cohort in our study. We had 63 elbows among 62 patients with a mean age in our cohort of 47 years old, who met the criteria inclusion described above, with an average follow-up of 747 days. That is including radiographic follow-up. 34 of these patients had anatomic press fit implants, 9 had smooth stem implants, and 8 had bipolar heads, with 12 non-anatomic press fit implants seen. Total, about 20% of our cohort ended up undergoing reoperation. It's 13 patients total, with 5 actually requiring prosthesis removal for complete loosening. We ran a kappa analysis on agreement between the 2 teams of reviewer, which showed fair agreement between the two teams for both radiocapitellar arthritis and stress shielding. And then among all cases, 84% were determined to have evidence of stress shielding by both teams of reviewers, and 24% were determined to have radiocapitellar arthritis by both sets of reviewers. If you go on to the next slide, Sachin. This is the multivariable analysis that was used to look at radiographic complications when looking at age, follow-up duration, Mason classification, and associated ligamentous injury around the elbow. We found that they were not associated with any stress shielding, any radiocapitellar arthritis, HO formation, or radiolucency. However, male gender was associated with a lower degree of arthritis, which was found to be significant, but gender itself was not associated with any differences in stress shielding, heterotopic ossification, or radiolucency. Interestingly enough, we also found that the use of bipolar head implants were associated with a lower degree of radiocapitellar arthritis, but implant type itself was not associated with either stress shielding, radiolucency, or the formation of heterotopic ossification. And then using the multivariable logistic regression to predict the odds of reoperation. If you advance to the next slide, Sachin. This was looking at the rate of reoperation in our cohort when comparing non-anatomic implants versus anatomic implants, as well as age, gender, duration of follow-up, as well as associated injuries. And we found that the only statistically significant factor that could, at least in our cohort, reliably predict the odds of reoperation was the use of non-anatomic implants, which were associated with a decreased odds of reoperation. As I mentioned earlier, age, gender, follow-up duration, injury severity, as well as other ligamentous injuries around the elbow were not associated with an increased odds of reoperation. So in summary, radiographic findings of stress shielding and radiocapitellar arthritis are known to be common after radial head arthroplasty. However, the clinical implication of these radiographic findings has yet to be seen. And then really the major takeaway that we found was that typically these are associated with long-term follow-up, usually greater than a year, but we were able to classify and quantify significant radiographic complications following radial head arthroplasty as early as 6 months, which we found interesting. And the kind of future of this study really, once I guess the pandemic settles down, is to actually bring these patients back in and assess the clinical relevancy of these radiographic complications and their effect on range of motion, pain, as well as some objective quality of life and functional measures. So that's where this is headed, but this was kind of the first phase in understanding what exactly the radiographic complications look like at the mid to long-term time period following these radial head arthroplasties.
Okay. Can you guys hear me?
Yes, Carol.
All right. I think I'm waiting for the video to transfer over. So thank you very much, Dr. Churches. Glad we could get our tech issues worked out. My name is Carol Lynn. I'm an orthopedic trauma attending at Cedars-Sinai Medical Center. Next, we're going to be hearing from Dr. Christopher Hart from UCLA. He's going to be talking about his project, The Clinical and Functional Outcomes of Patients Who Undergo Knee Fusion versus Amputation for Periprosthetic Joint Infection.
Thank you very much, Dr. Lynn. Yeah, my name is Chris Hart, PGY for UCLA, and the title of this talk is Clinical and Functional Outcomes of Patients Who Undergo Knee Fusion versus Amputation for Periprosthetic Joint Infection. Background for this study: knee fusion can be used as a static temporary antibiotic spacer as a first stage for periprosthetic joint infection, or as a definitive salvage alternative to amputation in patients with recurrent PJI. Again, the purpose of our study is to compare the clinical and functional outcomes for patients who undergo fusion versus amputation for PJI. We have an X-ray here showing a transfemoral amputation. We performed a retrospective review of 93 patients, 67 of whom underwent fusion and 26 who underwent transfemoral amputation between 2011 and 2018 for recurrent or persistent PJI. Patient characteristics were collected, including McPherson host type, as well as knee society scores. Our median follow-up was 52 months with a minimum of 12 months. The indications were for fusion included PJI explantation with significant bone loss, persistent infection of an antibiotic spacer, or reinfection of a prior two-stage reconstruction. Indications for amputation included failed fusion or patient preference. All the patients in our fusion group were treated with a cemented modular arthrodesis, also known as an endofusion, as seen in these postoperative knee x-rays. So looking at patient characteristics, there was no significant difference in age between the two groups, 66 for fusion, 69 for amputation. Focusing then on the McPherson host staging system, there was a higher proportion of patients in the amputation group who were host B and C types. And there was also a significantly higher proportion of patients in the amputation group who had extremities grade 2 and 3, which reflects an overall lower functional status in the amputation group as compared to the fusion group. All of the infection types in both groups were chronic in nature. Turning now to our clinical outcomes, there was no difference in the overall complication rate, 27% for the fusion group and 19% for the amputation group. And there was also no significant difference in the reoperation rate, 22% for fusion, 27% for amputation. The most common reason for reoperation in the fusion group was infection, and the most common reason for reoperation in the amputation group was non-healing wounds. Focusing specifically on the fusion group now, the operations that the patients received, if they did get a reoperation, it was fusion exchange 23% of the time, irrigation, debridement, and wound closure 62% of the time, fracture fixation 7% of the time, and then amputation 8% of the time. So there was a percentage of patients who were initially slated to receive definitive fusion who went on to amputation due to persistent infection. And then all of the patients in the amputation cohort, the reoperations they received were irrigation, debridement, and wound closure. Looking at functional outcomes now, there was a statistically significant difference in knee society scores. It was 26 for the fusion group and 17 for the amputation group. This is right at the cutoff for the MCID for knee society scores of 9. And importantly as well, we found that only 38% of the patients who underwent amputation were ambulating with a prosthesis at final follow-up. So to conclude, we found improved functional outcomes with fusion compared to amputation for PJI. We also found a low rate of ambulation with a prosthesis following amputation. This is somewhat lower than the rate found in the literature, which is generally reported to be between 50 and 60%. We also noted that there is a risk for in patients who are initially chosen for definitive fusion, there's a risk for persistent infection and potentially multiple reoperations, including transfemoral amputation. So that's something to consider in patients who choose to go the fusion route. Thank you very much to my co-authors and to OREF for allowing me to put on this presentation.
Okay, great. Next, we're going to be hearing from Gopal Lalchandani from University of California, San Francisco. And the topic is going to be inter-observer reliability of classification systems for injury severity and radiographic complications following radial head arthroplasty.
All right, thank you, Dr. Lin. Can everyone see my screen? So this project is on the inter- and intra-observer reliability of the arthroplasty classification systems. So as an introduction, systems that are commonly used for radiographic complications after radial head arthroplasty including radiocapitellar arthritis using the Broberg-Mori classification, which is a 4-tiered system for arthritis.
Doctor, can you make sure your microphone isn't covered?
Yeah, it's not covered. I can speak up. Is that better?
Yeah, that's a little better. Thank you.
Perfect. Thank you.
Oh, we lost you again. Oh, no.
No.
Now we have you again.
Okay, perfect. So there's a number of classification systems for radiographic complications after radial head replacement, including radiocapitellar arthritis, which is the Broberg-Mori classification of 4-tiered system for joint-based narrowing, including normal, joint-based, mild, moderate, and severe. There's also the Channellet classification for stress shielding, which looks at cortical thinning, and this is also a 3-tiered classification system. Finally, there's the Brooker classification for heterotopic classification in the hip, which is often applied to the elbow in research settings, and then the Popovic classification for radiolucency, where you identify zones of lucency to identify complications after radial head replacement. In this project, we sought to identify what the inter and intra-observer reliability of these classification systems is after radial head arthroplasty. And the prompting question, this question was prompted when working on Dr. Church's project that he previously presented, as a number of these classifications have been discussed, but it has never yet been studied as to whether or not these are reliable classifications. We thus identified 20 radiographs of patients after radial head replacement at our institution between 2006 and 2019. And we had 6 reviewers, 3 residents, and 3 attendings who independently classified the radiographs from each patient according to each classification. Each reviewer performed a second set of reviews 1 month after their initial review. In terms of our results, we found that the inter-observer reliability of each classification system ranged from slight except for the radiolucency when looking at number of zones. And when comparing reliable staff when looking at the Brooker classification. However, there were no other differences identified. When looking at intra-observer reliability, we had viewers identify or look at the same classifications about a month later. And we found, again, fair to moderate, except for the Popovic classification, which was almost perfect when identifying number of zones. And again, when comparing results between staff and trainees, we found that trainees actually had a significantly higher mean intra-observer reliability for the Channellet system, with no differences between other groups. So as a conclusion, we found that the Brooker classification and the Popovic classification fared the best out of all these classification systems, with substantial inter-observer reliability and almost perfect intra-observer reliability. However, all other classifications range from slight to fair when looking at inter-observer reliability, which was consistent with our hypothesis that these classifications, given that they have not been clearly, have not always been clearly defined in the literature, may not have the best reliability. And finally, when comparing the results of staff and trainees, we found interestingly that it was inter-observer reliability was slightly higher amongst trainees for the Brooker classification, as well as intra-observer reliability for the Channellet classification. Here are my references.
Carol, I think you're on mute.
Sorry about that. So next we're going to be hearing from Sai Devana from UCLA, and the topic is going to be outcomes of patients undergoing conversion of knee arthrodesis for prosthetic joint infection to second stage endoprosthetic reconstruction.
All right, hopefully everyone can hear me. Thank you, Dr. Lin. My name is Sai Devana. I'm a PGY3 at UCLA. And I want to thank you all and OREF for letting me talk about the outcomes of patients undergoing second stage reimplantation following knee endofusion. So a little bit of background. Knee fusion is a salvage treatment for recurrent periprosthetic joint infection, PJI, or can be used as a temporary spacer. Knee fusion provides knee stability, pain relief, and enhanced mobility, but there exists a high rate of patient dissatisfaction in the literature due to social and physical limitations associated with fusions. Consequently, a significant number of patients who show evidence of PJI eradication following fusion elect for a fusion takedown with conversion to reimplantation endoprosthetic reconstruction, REI, which is a technically challenging procedure with a high incidence of complications per the literature. 2 meta-analyses have shown good clinical results in patient satisfaction scores following conversion of fusion to REI, despite a high risk of postoperative complications. Currently, there remains a debate amongst authors and a lack of consensus in the literature regarding fusion takedown to REI. That being said, the purpose of this study was to evaluate the infection-free survivorship of patients undergoing conversion of fusion to REI and to identify any host factors associated with REI failure. So this was a retrospective review of 56 patients who underwent conversion of fusion to REI from 2010 to 2019 with a mean of 37-month follow-up. All the patients were stratified according to the McPherson host staging system, which Dr. Hart referred to earlier, which is on the right there, comprised of 3 different columns: infection type, systemic host grade, and local extremity grade. As far as the index infecting organism, that was documented as a study based on pre-fusion aspiration or intraoperative cultures at the time of fusion. Knee society scores were recorded pre-REI and at most recent follow-up. Lastly, SAS software was used to calculate relative risk for relevant patient factors using Poisson regression. So starting with patient characteristics, mean age was 67 years old with an even split of gender, and mean time of fusion to REI was 220 days. In terms of the leading infecting organisms, Staph A and Epi were the 2 highest. And as far as McPherson host staging system, all the patients were infection type 3, which is a chronic late infection. And the majority of patients were host B and extremity 2, which means that they had 1 to 2 compromising factors. In terms of clinical outcomes and complications, so following reimplantation, overall infection-free survivorship of REI was about 66%. And excluding infection, there was a 96.4% survivorship. There was an overall complication rate of 21.4%, again, excluding infection. This is significantly lower than a recent meta-analysis from 2016, which reported a complication rate of 47%. And this might be due to the fact that most studies on this topic are dated back to over a decade ago, which has now doesn't take into effect the last 10 years of improvement in technology and implants. So that's one possible explanation. Additionally, there was a significant improvement in KSS scores pre and post conversion, which overall makes sense because the range of motion from an endofusion to a prosthesis should inherently improve. Lastly, in order to determine if infectious organism or McPherson host staging had an association with reinfection rate, we calculated relative risk with Poisson regression modeling, which showed no statistical significance across the board. So in conclusion, this is the largest fusion to endoprosthesis cohort study to our knowledge out there in the literature. And this is the first study to evaluate reimplantation failure secondary to PJI infecting organism and host type. And we've concluded that REI is a good option for patients with fusion who remain infection-free and are unsatisfied with their functional outcome. Also, approximately 2/3 of patients who undergo conversion from fusion to REI have infection-free survival at midterm follow-up. And this is pretty consistent with other studies published. And lastly, index infecting organisms and McPherson host type does not appear to be significantly associated with infection risk or reinfection risk. Thank you.
All right. Next, we are moving along. We're going to be hearing from Stephen Craig from Loma Linda University. And we'll be hearing about the fragility of statistically significant findings from a randomized clinical trials of surgical treatment of humeral shaft fractures, a systematic review.
Is it working?
Yeah, here we go.
All right, good morning. I'm Craig Morris, coming from Loma Linda, presenting our systematic review, looking at the fragility of the findings in RCTs looking at humeral shaft fractures. It's online. Sorry, let me try this one more time. Is that better? Background, humeral shaft fractures are relatively common. The majority can be treated non-operatively. However, there are some surgical indications, including open fractures, polytrauma patients, floating elbows, and then those that fail close treatment. When you do need to do surgery, there's options of external fixation. There's plate osteosynthesis, both open reduction as well as MIPO or minimally invasive, and then also locking versus non-locking plates. And then finally, intramedullary nails. There have been a number of studies looking at these treatment options, and there's no clear consensus. So we wanted to apply the fragility index to further evaluate the literature. The fragility index has been published previously and then more recently applied to the orthopedic literature. And very briefly, it gives you a quantitative value for how many participants' outcomes would need to be changed in order for a statistically significant event to become non-significant. And so our study was to determine how robust the data is on the treatment of humeral shaft fractures, and we wanted to do that by systematically applying the fragility index. We hypothesized that the median fragility index would be less than 3, which was consistent with what we've seen elsewhere in orthopedics. The higher the fragility index, the more robust the result. And then if the fragility index is less than the number lost to follow-up, you have to question those results because the inclusion of those participants alone would potentially be enough to change the outcome of the study. So first, we identified randomized controlled trials. We did that with our systematic searching of the databases. The inclusion criteria were largely dictated by the requirements of the fragility index itself.
Stephen, your slides aren't advancing, and you're not on presenter mode.
Not sure what's going on.
You try sharing your entire screen.
Yeah. Are you seeing anything at all?
Oh, I think we might have been seeing your notes mode.
Let me try. Sorry. How about, is this any different? Is this better?
Yes.
That is much better.
Okay. Okay, so the methods, sorry about that. We identified randomized control trials, and these are the inclusion criteria based on what you need in order to calculate the fragility index. These are our exclusion criteria. And then we extracted data from those studies, and then we calculated the fragility index, both for each complication individually, as well as a sum total of complications in each RCT, and then also looking at secondary surgeries. So this is our flow chart here showing how we got to the 15 RCTs that were included in analysis. These are the papers we included, giving you an idea of how many patients were enrolled, the number lost to follow-up, as well as whether the studies did a power analysis or not. And then these are some characteristics of the studies. Again, the sample size, what comparison treatments were being compared in each study. And then of the outcomes that we looked at, how many of the included studies did they report data for those outcomes? So these are the fragility index values. 81 out of 91 ended up being calculated to be 0. This is a histogram showing you again the fragility index value for each outcome. And then I highlighted the 2 most significant results because these were the only 2 where the fragility index value exceeded the number lost to follow-up. So we said, is it just a numbers issue alone? But there was no correlation between sample size and the fragility index. So just a larger sample size alone did not correlate with more likely to be a non-zero fragility index value. These studies also all evaluated continuous variables. I just summarized some of those results here, but the fragility index cannot directly analyze that data or add to the commentary on that data. So the discussion, basically there were only 2 results where the fragility index exceeded the number lost to follow-up. Lower incidence of iatrogenic radial nerve palsy with open reduction versus nail, and then lower rate of total complication with open reduction versus nail. The median FI in total was actually 0. And what does this mean? Well, one of 3 things. One, the studies we included are either flawed in design or they're underpowered to identify the difference. 2, there not really is a difference between these treatment options. Or number 3, the difference in the treatment options is captured only by continuous variables and not by the dichotomous variables that we can study with the fragility index. So the limitations of our study, the fragility index, we can only look at dichotomous outcomes. We can't comment anymore on continuous variables. And because of that, we're restricted in the studies we can include. And then the fragility index itself has some inherent limitations. Specifically, it revolves around this threshold of a p-value of 0.05, which is, somewhat arbitrary, but generally agreed upon in statistics. And then the last thing is, as we're looking at these dichotomous outcomes, a lot of the studies, that was not the primary outcome of the study itself. And so the powering of the study might have been geared towards a different variable. And so the conclusion of our study is there is not robust data to recommend one treatment option over another on the basis of these complications or secondary surgery. And therefore, until we have more robust data, we recommend you use whatever technique you're most comfortable with. Thank you.
Great. Next, we're going to be hearing from Heather Roberts from UCSF. She'll be talking about motivations and impact of international rotations in low and middle income countries for orthopedic surgery residents. Are we on the same page?
Great. Can you all hear me?
Yes.
Wonderful. So thank you. I'm a PGY4 at UCSF presenting the study that Dr. Lin mentioned. So let me see, I can't advance my, there we go. For some background, there is growing interest in low and middle income country rotations for orthopedic residents. A study in 2015 showed that 1/4 of orthopedic residency programs had an international training experience opportunity. Many studies have shown that these rotations are shown to be positive for North American residents, but there really hasn't been much to look at how these rotations affect the local low and middle income country surgeons and trainees who host North American residents. So the purpose of our study was to explore North American orthopedic resident motivations for participating in these rotations and the perceived impact of these rotations among host surgeons and trainees. We did this through 3 surveys. We first surveyed North American orthopedic residency site directors at programs that do have such training experiences to assess the logistics of the rotation. We had a second survey that assessed North American orthopedic surgeons and trainees who had participated in international training experience as a resident, and a third survey for surgeons and trainees in low and middle income countries who had hosted a resident from North America in the past 10 years. Surveys 2 and 3 asked about motivations and perceived impact, respectively, on a 5-point Likert scale. We distributed these surveys through the COACT network, which is a consortium of orthopedic academic traumatologists that focuses on international surgery, and snowball sampling, where people sent the survey to those to contacts who were known to be relevant. So to share some of our results, we had 26 site director responses. Half of the programs with international training opportunities have started such rotations within the past 5 years, so many are quite new. 69% of the rotations are 2 weeks or shorter, and over 1/3 work at low and middle income country hospitals that don't have their own local residents. For surveys 2 and 3, there were 136 North American responses. You can see in this top graph where these North American residents have rotated, the majority being in Latin America and Sub-Saharan Africa, and most rotated as PGY 3, 4, and 5s. There were 51 host respondents, 59 of which were current trainees. You can see in this bottom graph the distribution of where these host respondents came from. Notably, 13% of trainees and 52% of faculty had traveled to their partnering high-income country site for an observership or a rotation. And the ones who had not traveled stated that a major limitation was lack of an invitation. This graph is really busy, but it shows the average Likert score for the North American motivation and the host perceived impact for a number of different domains. And I'd like to highlight two that we thought were important. One is this idea of increasing local access to surgical care, which North Americans cited as a strong motivator for participating in these rotations. But hosts perceived to be a lower impact, a significantly lower impact of increased access to surgical care. On sort of a similar vein, the North American residents cited knowledge transfer, in other words, teaching the host surgeons, not nearly as important as the hosts perceived this to be an impact. So from this, we felt that there was a discordance between the North American residents and the hosts with respect to the value and the impact of these rotations, as in North Americans felt that they were going to increase surgical care for hosts at the host institution, whereas the host felt that the impact was more through knowledge transfer rather than surgical capacity. So to highlight some of our conclusions, there's growing interest in low and middle income country rotations for North American orthopedic residents, which suggests to us that there's a need for guidelines around these rotations. Like I mentioned, there's this discordance between providing surgical care versus bringing knowledge, which we think is an important thing to recognize in setting up these rotations. We also found that the impact of the rotation was greater on the local host residents than on the faculty, which suggests that these rotations may have a higher benefit if they're performed in local training institutions. There were some signs of lack of reciprocity, such as the observership opportunity example that I mentioned. And finally, we had an opportunity for free text responses for the positive and negative impacts of these rotations. And there were a number of negative perceptions from the hosts that were concerning. For example, a couple people had mentioned that there were incidents of racial discrimination from these visiting residents. So while the opportunity for the positive impact on the LMIC hosts is really strong, there are further research to explore these negative perceptions is important and underway. Thank you for your attention.
Okay, and rounding up the end of this section, next we're going to be hearing from Ashish Mittal from the St. Mary's residency. Speaking about graft failure in adolescent patients undergoing adult type ACL reconstruction with bone patellar tendon bone or hamstring autograft.
Great, thank you. Be able to see my slides okay?
Yes.
Okay, great. My name is Ashish Mittal. I'm a PGY4 resident at St. Mary's Medical Center in San Francisco. I appreciate the privilege of being able to present here. I'll be talking today about graft failure in adolescent patients undergoing adult type ACL reconstruction with bone patellar tendon bone versus hamstring autograft. We don't have any disclosures for this study. Starting with some background, ACL injuries continue to increase in pediatric and adolescent athletes. This is partly thought to be due to an increase in intensity and frequency of modern day sports training. Athletes often start participating in sports year-round at an earlier age and start specializing in sports earlier. ACL injuries represent about 25% of all adolescent knee injuries. And in adolescent patients nearing or at skeletal maturity, patients can be treated with an adult type ACL reconstruction. Following reconstruction, adolescent patients have been reported to have a higher rate of graft failure compared to adult patients. So our study goals were to evaluate outcomes, including graft rupture between patients undergoing adult type ACL reconstruction between bone patellar tendon bone versus hamstring autografts. In order to do this, we conducted a retrospective review of patients under the age of 21 that were undergoing adult type ACL reconstruction with the two prior mentioned autograft types between 2011 and 2019. 269 patients were included for analysis, 70 patients who underwent reconstruction with BTB autograft and 199 who underwent reconstruction with a hamstring autograft. This was a single surgeon study, and statistical analysis was done using t-test and Fisher's exact test with significance set, the p-value less than 0.05. So what we found was that average age of patients in both cohorts was 17. The percentage of female patients was higher in our cohort with hamstring autograft reconstruction. The percentage of patients participating in high-risk sports and overall compliance of patients was similar in both cohorts. Our average follow-up time was 2.1 years. We did find that graft diameter was on average larger in patients undergoing reconstruction with BTB autografts. This was statistically significant with 9 millimeters on average in patients undergoing reconstruction with BTB autograft compared to 8.3 in patients undergoing reconstruction with hamstring autograft. Our rate of reoperation was slightly higher in patients with a hamstring autograft, 10.6% compared to 8.6%. This was not statistically significant. Graft failure similarly was slightly higher in patients undergoing reconstruction hamstring autograft, 5.5% compared to 2.9% with a BTB autograft. This also was not statistically significant. The average time to revision surgery was 1.7 years, and 46% of patients had revision ACL reconstruction with a different surgeon. This is looking at different preoperative and postoperative factors in patients with or without a graft tear. What we found was that age was similar in patients with or without a graft tear. There was a higher rate of non-compliance in patients who had a graft tear, but this was not found to be statistically significant. There was also a higher risk of participation in high-risk sport in patients who suffered a graft tear. So our conclusions were that adult type ACL reconstruction adolescent patients has a low rate of graft failure and overall revision with BTB and hamstring autograft. Graft diameter is higher on average in patients undergoing reconstruction with a BTB autograft. There was no statistically significant difference we found in graft rupture rate between patients undergoing reconstruction with BTB versus hamstring autograft. We also noted that many patients have a change in surgical provider for revision surgery. We hope to increase the power and follow-up for the study in the future. I'd like to thank all of my co-authors for their integral contributions, Dr. Pandya for making all of this possible, and for the Orthopedic Research and Education Foundation for putting on this excellent symposium. Thank you.
All right. Unfortunately, I think because we are running behind of time, we won't be able to entertain questions for right now. I think if you do have questions regarding these presentations, please put them in the chat. And if there's time at the end of the day, we can address them then. So we'll move on to the next session.
Thanks, Dr. Lin. Yeah, that'd be great if you could enter questions in the chat for the authors. We're going to go ahead and start the next session. First is Zachary Burke from here at UCLA. Zach, you want to go ahead?
Yes. Hi, Dr. Zhu. Can you hear me?
Yeah, we can hear you.
Okay, thank you. Thank you to Dr. Su and to the OREF for the opportunity to present here today. I'm in my final year of training at UCLA and excited to share some research that I did in the lab of Dr. Bernthal with some collaborators who are very much involved in this project. So as we all know, orthopedic biofilm infections are a leading cause of morbidity and mortality in orthopedic surgery. Biofilms confer over 1,000-fold increase in antibiotic resistance when they are fully formed. The gold standards for biofilm eradication, such as irrigation and debridement and antibiotic-loaded bone cement, are essentially unchanged in the last 20 to 30 years and are unsuccessful in 10 to 50% of cases. Many researchers and clinicians have suggested that we should treat biofilm infections similarly to cancer with oncological principles of cellular level eradication and targeted therapies. To that end, our lab partnered with Trellis Biosciences to bring targeted therapies to the world of orthopedic biofilm infections. Trellis developed a monoclonal human antibody that binds a critical protein in the DNA, the extracellular DNA matrix of biofilms. The DNA B2 protein binds and acutely folds extracellular DNA to form the tertiary structure of orthopedic implant biofilms. The implant or the antibody was originally developed with the idea to be used in endocarditis, but we were able to convince Trellis to divert some of their resources to the significant problem of orthopedic biofilm infections. The implant binds with high affinity to an epitope that is highly conserved amongst gram-negative and gram-positive pathogens that are frequently implicated in biofilm infections. This antibody eradicates the biofilm scaffold in 6 to 12 hours. We assayed this novel antibody TRL-1068 in our validated model of spinal implant infection, which you've already heard about today, in which a stainless steel wire is press fit into the L4 process, spinous process of black 6 mice, and is subsequently inoculated with Zen36 bioluminescent Staph aureus to allow for bioluminescent monitoring in vivo of bacterial burden in a region of interest, as you can see here inscribed over the implant. The experimental design for our study was 4 groups: a isotype controlled with vancomycin, that's an inactive isotype, an active antibody TRL-1068 with vancomycin, a vehicle control, and a sterile group. The surgery was performed 4 days before the first treatment. Antibody injections were performed on day 1 and day 4 of treatment. Bioluminescent imaging to quantify in vivo bacterial burden was done for 3 weeks, starting with the first antibody injection. BID vancomycin was given to the mice for a 2-week period, starting on the same day as the second injection. The mice were sacrificed and CFUs were harvested from the implants using sonification on day 32 after treatment. Here we see our in vivo bioluminescent graph, which is a measure of bacterial burden in the experimental groups that were previously described. I'll draw your attention to the orange line, which is the vehicle control infected rats that had no treatment, the gray line, which was a vancomycin treated group that had an inactive isotype, and the red line, which is the active TRL-1068 antibody with vancomycin. The red line shows a decrease in bacterial burden compared to controls in all groups across the treatment period from the original antibody injection to the end of antibiotics. We also assayed the rate of bacterial kill by comparing the slopes of the decline in bacterial burden via bioluminescence and found that there was a significant decrease in the rate of, or rather a significant increase in the rate of bacterial kill compared to controls. Most importantly and most impressively from this study, the CFUs that were enumerated from the implants at the end of the experiment were significantly less in the vancomycin and active antibody group, as seen in the graph on the left. And notably, there were no bacteria elucidated from the active antibody group at all at the end of the study, as compared to 22% of implants that had vancomycin and inactive antibody. So in conclusion, TRL-1068 is a promising and novel therapy for the treatment of orthopedic implant infection. It binds to the DNAB2 protein and degrades biofilm scaffolds. In our in vivo analysis, this antibody decreased bacterial burden and increased the rate of bacterial kill in a validated mouse model of spine implant infection. And most impressively, no CFUs at all were enumerated from implants in the mice treated with the vanc and the active antibody, compared to 22% in the control group. Limitations of this study: it's a simplified model, 1 implant, 1 bacteria, 1 antibiotic. The bioluminescent imaging has a limit of detection, and towards the end of the study, we approached that limit in all groups. The next steps in this particular avenue of research I'm excited to share, the FDA has approved first in human trial in otherwise healthy PJI patients scheduled for 2-stage arthroplasty. Phase 1 double-blind trial of TRL-1068 is slated to begin in December of this year. I'd like to really thank Dr. Bernthal for all of his support. The lab members listed on the left were integral in this study: Trellis Bioscience, Larry Calvar, Stephen Risser, Edgar Canario, and the OREF Foundation for the chance to present today. Thank you.
Thank you, Zach. Next up is Peter Shui, talking about primed cellular immunotherapy to prevent or treat spine implant infection. Go ahead, Peter.
All right, can everybody hear me? Hi, good morning, everyone. My name is Peter Stray. I'm one of the orthopedic surgery residents here at UCLA. I want to thank the OREF for giving me the opportunity to share some of our lab's work with all of you today. My co-authors and I have no relevant disclosures for this project. So orthopedic implant infections are a devastating postoperative complication, which not only result in significant patient morbidity, but also create an enormous financial strain on our healthcare system. As a result, there has been a tremendous amount of effort dedicated to new research strategies to treat these infections, such as implant coatings and new hybrid antibiotics. However, there's been relatively little attention paid to methods of augmenting the host immune system to treat these infections. Interestingly, recent breakthroughs have demonstrated that the innate immune system can then be harnessed to augment the host immune system and potentially treat these infections. Specifically, macrophages have been shown to be able to undergo a new immunological technique called priming, in which they're exposed to bacteria ex vivo and then reintroduced into a host. And this has been shown to be able to decrease infection burden and accelerate infection clearance in a mouse model of skin infections. So our goal was to evaluate the efficacy of these prime macrophages in a Staph aureus-mediated orthopedic implant infection using a well-established in vivo mouse model of spine implant infection. Our hypothesis is that the addition of these prime macrophages will trigger an enhanced host immune response, thereby decreasing bacterial burden postoperatively and decreasing the overall incidence of implant infections. Our experimental design is illustrated in the figure above. First, stem cells are harvested from the medullary canals of mouse tibias and femurs. These stem cells are then grown in vitro and then eventually differentiated into macrophages. The macrophages are then primed via exposure to heat-killed Staph aureus. Again, this is done ex vivo. And then they are isolated, collected, and eventually injected into the surgical site of our mouse model of spine implant infection. A few of my colleagues have already touched upon our mouse model of spine implant infection, but just to quickly recap, it involves the placement of a stainless steel pin into the L4 spinous process. We inoculate a bioluminescent strain of Staph aureus directly at the surgical site, and then we are able to monitor the bioluminescence of the bacteria longitudinally as a surrogate marker for bacterial burden. In this particular experiment, we actually sacrificed a small proportion of animals on postoperative day 1. The skin and soft tissue overlying the surgical site, as well as the mouse spleen, were excised and prepared for histological analysis. So here on the right is a histology slide of the mouse skin, and you can appreciate a large aggregation of brown cells, which are the macrophages. And this is proving that the prime macrophages we injected are indeed close to the surgical site. Analysis of splenic tissue demonstrated that the primed cohort, the mice that received the prime macrophages, did indeed mount a systemic immune response. This is demonstrated by the reactive follicle expansion, which you can appreciate here as these large aggregates of purple cells, which we only saw these changes in the splenic tissue in mice that received the prime macrophages and not in our infected control group, which did not receive any prime macrophages, shown here on the left. Despite the augmented immune response, we did not appreciate a decrease in the infection burden over time. So in this figure, we have a postoperative days on the x-axis, and then bioluminescence, a logarithmic bioluminescence on the y-axis. The red line is the bacterial bioluminescence for the primed cohort where they received macrophages. As you can see, when you compare it to the blue line, which is our infected control, there is no decrease in bacterial burden. At the conclusion of the experiment, animals were sacrificed, and similar to previous spine studies, we also again looked at CFU analysis for both the soft tissues as well as the implants. We did not appreciate a decrease in the infection rate of soft tissues or implants in the primed cohort compared to the infected control group. So in our observational study, we saw that the injection of prime macrophages into mice did indeed trigger a systemic immune response. However, this systemic augmented immune response did not actually decrease Staph aureus infection burden, nor did it decrease the overall incidence of infected implants at the end of the experiment. We believe that future experiments, which may be able to improve the localization of prime macrophages to the site of infection, may yield different results. So in conclusion, despite the success of this novel cellular immunotherapy for a mouse model skin site infection, there remain numerous translational challenges for its application in a mouse model of orthopedic implant infection. Thank you very much. Happy to take any questions.
Thanks, Peter. Next is Dr. Erica Roddy from UCSF on the outcomes of acute but not delayed reverse total shoulder arthroplasty for proximal humeral fracture and their equality to those after rotator cuff arthropathy. Dr. Roddy, please go ahead. Dr. Roddy, I think you're on mute. Dr. Roddy, you're muted.
Sorry about that. I'll try again. Can you guys hear me now?
Yes.
Awesome. So good morning, everyone. I'm excited to talk to you all today about outcomes of reverse total shoulders for proximal humerus fracture and their comparison to outcomes for cuff tear arthropathy. So in terms of background, proximal humerus fractures are the third most common fracture in patients greater than 65. And although surgical indications are controversial, displaced 3- and 4-part fractures in active patients may have poor outcomes with non-operative treatment. And reverse total shoulder arthroplasties are becoming a more popular treatment option, with some evidence to show that reverse arthroplasties have better outcomes compared to open reduction and chill fixation. However, there's no data looking at the difference in outcomes for reverses for fracture versus those for cuff tear arthropathy, which is the classic indication for reverses. And studies in total hips for femoral neck fractures have shown inferior outcomes compared to total hips done for osteoarthritis, with higher rates of dislocation, reoperation, and in-hospital complications. So our study question was, are outcomes of reverse total shoulder arthroplasty for proximal humerus fracture worse than those for cuff tear arthropathy? We performed a retrospective cohort study of patients undergoing primary reverse total shoulders at our institution between 2008 and 2019 with minimum 1-year follow-up. And we divided patients into 4 groups: those undergoing reverse for acute proximal humerus fracture, which was defined as undergoing surgery within 6 weeks of injury; those who underwent reverse for fracture non-union or malunion; those who had failed prior surgery for their proximal humerus fracture; and those with cuff tear arthropathy. And our primary outcome was ASCS score at most recent follow-up. So in terms of our demographics, in total, we had 287 patients in our study with the distribution as seen in the top row here. As expected, patients with acute fracture were slightly older, more likely to be female, and had slightly lower BMIs. And patients with failed prior surgery were slightly younger on average. Otherwise, the 4 groups did not differ in terms of number of comorbidities, smoking status, or length of follow-up. We found that patients who had failed prior surgery had lower implant survival rates, with 78% survival at 5 years, compared to patients in the 3 other groups who had 95% survival or higher at 5 years. And we found that the factors associated with higher ASCS scores on univariate analysis included male sex, lack of revision surgery, and fewer comorbidities. We found that patients' mean ASCS score was very similar for patients with cuff tear arthropathy and those with acute fracture, but patients who had failed prior surgery or had a malunion or non-union had significantly lower ASCS scores. And these findings persisted in multivariate analysis, controlling for all factors associated with ASCS score. As you can see in this chart, patients with failed prior surgery and patients with a malunion or non-union had ASCS scores that were nearly 20 points lower than those with cuff tear arthropathy. By contrast, patients with acute fracture had scores that were nearly identical to those with cuff tear arthropathy. And similar findings were seen in terms of range of motion. We found that patients in the failed prior surgery group and those in the malunion or non-union group had lower range of motion in all planes tested compared to patients with cuff tear arthropathy. By contrast, patients with acute fracture had similar range of motion overall, although with a slight trend towards decreased external rotation compared to the cuff tear arthropathy group. So in conclusion, surgeons can counsel their patients that reverses done for acute proximal humerus fracture leads to similar improvements in patient outcomes compared to elective reverses done for cuff tear arthropathy. However, outcomes of delayed reverses for proximal humerus fracture are considerably worse, and this may have counseling implications for your in-between patients. And in patients who may be heading towards a non-union or malunion, at the 6-week mark, you may consider intervening surgically earlier. So I'd like to thank my co-authors and the opportunity, and you guys for the opportunity to present here today. Thank you very much.
Thank you. Next will be Dr. Aaron Kim from UCSF on the rates and predictors of operative management of proximal humerus fractures in adolescents. Dr. Kim?
Great. Good morning. Can you all hear me? And
yes.
Yeah. All right, great. So my name's Erin Kim. I'm from UCSF. I'll be talking about rates and predictors of operative management of proximal humerus fractures in adolescents. No disclosures. So non-operative management of proximal humerus fractures in the pediatric population has yielded excellent clinical outcomes, as the majority of these are non-displaced. Furthermore, the proximal humeral epiphysis is responsible for 80% of humeral growth in length and has considerable remodeling potential. But the treatment algorithm in adolescents has been more controversial due to decreased remodeling potential in this cohort. Pavlon et al. Recommended treating children under 10 and older than 13 as distinct patient populations, as their prognosis is likely to be different due to the closing physis. In practice, Hanonen showed that 20% of children older than 12 years were treated operatively compared to only 1% in children under 9 years. However, the majority of these studies are small case series, and there's no large study looking specifically at adolescent patients. So the purpose of the study was to investigate recent trends in the treatment of proximal humerus fractures in the adolescent population and investigate predictors of operative management. For the methods, the Pediatric Health Information System is a database that spans across 52 children's hospitals in the US. The inclusion criteria was patients between the age of 10 and 18 who sustained a proximal humerus fracture between 2004 and 2019. We excluded open fractures. And we found that there were 17,515 proximal humerus fractures that were identified. 11.9% of these were treated operatively, and the mean age of these patients was 12.5 years. And 37.5% of these patients were female. We also found that the operative patients tended to be older, 13.4 versus 12.4 years, and there was a higher rate of operative management in boys compared to girls. Rural areas had a higher rate of operative treatment, 20% compared to 10% in urban patients. So we also did a multivariate analysis that showed increased odds ratio of operative management with male, gender, residents in the South. And odds of operative management were lower in more recent years of treatment and in urban settings. There was a statistically significant effect on income on operative management, but the effect size is very small. There was an overall trend of higher operative management in patients who are 13 and older, as expected. And we also looked at the rate of operative treatment by year. Interestingly, since 2015, there is a significantly decreased rate of operative treatment across the board. So perhaps the most critical decision for a surgeon is deciding when to operate, and the orthopedic literature in previous decades uniformly recommended non-operative management of these fractures, whereas starting from the 2000s, gradually there are more studies that showed good treatment with operative management, especially in older children. Our analysis identified older age, male gender, residents in the South or urban settings, and income as predictive factors of operative management. Interestingly, Cruz et al. Also was a database study that showed that admission to a non-children's hospital was associated with increased operative rates, 45% versus 29%. This goes along with our results that, interestingly, where you are treated affects whether you get surgery. From the timeline that we looked at, 2004 to 2019, the rate of operative management in adolescents decreased from 15% to 8.9%. This is a pretty acute drop at this timeline, and we can't fully explain why this trend happened, but there are a few key publications during this period that may have shaped management. The CHOS paper showed that in non-op and op match cohorts, there was no difference in complications, rate of return to activity, or cosmetic satisfaction, but functional outcomes tended to be higher actually in the non-operative cohort. Binder was another study that showed that 96.9% of non-op patients had excellent results, with actually poor results in the surgical group. And Y looked at patients who are under 11 and 11 and older who are treated non-op, and there was no significant difference in constant scores in these two groups. So some strengths of our paper is that it's a large sample size and it was powered to identify significant trends in treatment. And this specifically examines the adolescent population, which is an under-researched area when it comes to proximal humerus fractures. Weaknesses of our study is that data comes from urban children's hospitals predominantly, so it may not be as generalizable to more rural settings. And database studies are limited by coding misclassification and info such as displacement. So in conclusion, there's been a trend towards non-operative management of adolescent proximal humerus fractures, and patients who are older, male, and live in rural settings are significantly more likely to receive operative management, but further study is needed to investigate these trends and outcomes. Thank you.
Thank you. Our final resident presenter today is Dr. Max Giganti from Good Sam on altered cortical activation after ACL reconstruction during single leg balance task. Dr. Giganti?
Hi, thank you. So I'm Max Giganti. I'm a resident at Good Samaritan in Corvallis, Oregon, and my project is on altered cortical activity during single leg balance in ACL reconstructed patients. I'd like to thank my co-authors for helping and publish this paper just a few months ago in Translational Sports Medicine. We have no disclosures. So some background.
Are you sharing?
Yeah, can you see my screen? Sorry, can you see my screen?
I don't see yours.
I cannot, no.
Oh, sorry. Let's see. Can you see it now?
Yep, coming up. Thank you.
All right, sorry about that. Just to jump to where we were at, no disclosures. So some background with ACL is it is the most common injured ligament in the knee, and after ACL reconstruction, there remains a 20 to 40 times greater risk of re-rupture when returning to high-level activities, and this is contralateral or ipsilateral limb. So functional stability of the knee joint is primarily regulated by sensory motor function. And this is an integration of the somatosensory region, vestibular region, and the visual motor processes. Impaired balance after ACL reconstruction does indicate neuromuscular control dysfunction, and this can alter movement patterns and increase the risk of re-injury. So the purpose of our study is to look at the cortical activation patterns during single leg balance tasks between our reconstructed individuals and healthy controls, as well as the effects of visual feedback and the relationships between cortical activation, knee functional outcome, and the balance performance. And overall, to advance our understanding of the neuromuscular control mechanisms and any changes in the CNS associated. So our hypothesis is that these patients who completed rehabilitation and return to sport will have comparable balance scores with different cortical activation patterns and higher cortical activation with better knee function. So here's our demographics. We had relatively sex-matched groups, age around 23 to 24 here, relatively matched BMIs, and time from surgery between 2 and 3 years with a minimum cutoff of 6 months, those included. So materials and methods, on the right here, you'll see our Biodex balance machine that a patient is balancing on one leg with a 32 channel EEG that submits instantaneous information to our laptop and EEG software, along with the monitor here that gives the visual feedback. So a statistical analysis. So we did two-way repeated ANOVAs and we looked at correlations. And our results showed that there was better balance scores with the addition of visual feedback in both groups. We saw greater frontal theta activation in both groups with visual feedback. And frontal theta is just a frequency band on EEG. It's related to focused attention. We also saw an interaction effect of group by condition for parietal alpha 2. And alpha 2 can be described as somewhat of a cortical idling or a decreased recruitment of neurons. So looking at this specifically, we saw opposing trends in our control group and our ACLR group. Decreased parietal alpha 2 in the control group with visual feedback, while the ACL group had an increase in this frequency band. So here we have a topographical map of a bird's eye view of our EEG activity. So on the left here, the frontal theta in both groups significantly increased with visual feedback. When we look at our control group, particularly in the parietal region, they actually had decreased recruitment of neurons with the addition of visual feedback, where our ACL group didn't significantly change. However, they actually went in the opposite direction and had an increase in activity. So the conclusions from our study is that there are cortical activation patterns. They are different during single leg balance tasks between our two groups. The two groups did not respond similarly to visual feedback. And based on this, with similar balance scores between our two groups, there may be an involvement of a compensatory mechanism after this reconstruction that can describe how there's different cortical activation, yet similar balance ability. Here's some references, and thank you very much for having me.
Thank you, everyone, for those excellent presentations. We're a little short on time, so I think, again, for the last two sessions, if you have questions, please direct them to the chat or directly reach out. But I think we're going to move forward to our guest speaker. A couple of housekeeping items, if the judges could please submit their scores. And actually, if all the residents could also please submit your scores, because we'll be giving a resident prize for the ones you vote for. It's my great pleasure to introduce our keynote speaker, Sam Morshid from UCSF. Sam has been a tremendous leader in the issue of global health, and we've had the opportunity to have our programs collaborating together, and I couldn't be more delighted to have him give us a talk today. Sam, would you like to go ahead, please?
Can you all see my screen?
Yes.
Fantastic. All right. Well, first of all, I want to congratulate all of the presenters from this morning. Really a fantastic group of presentations and excellent research. So I congratulate all of you. I'd like to thank Nelson as well as Dr. Hornacek and UCLA for inviting me to present this this description of our work. It's a platform that we've been working on for about 2 decades, building on our international program that I'm going to describe for you. Let's see if we can advance here. I have no relevant financial relationships or things to disclose with regards to this presentation, and there are a lot of pictures, many of them taken by myself, and we have consent for the use of all images that you're going to see here today. So the first thing I'm going to do is I'm going to try to convince you that you all, as orthopedic surgeons in training, and those of you who are out of training, that you have a stake in global health, global surgery, and what you do really has a difference and can make a big difference. And there are also a lot of opportunities. Part of the reason that I think this is an appropriate presentation for a group of residents is to really empower any of you who are interested in this kind of work, that you can do this. This is something when I was a trainee that didn't exist, and I'm going to describe to you now that it's become a program that really is built around the work of a lot of our trainees. I'm going to introduce you to the IGOT model. IGOT is our Institute for Global Orthopedics and Traumatology. You'll learn a little bit more about what that is. And I'm going to present some highlights of our program, as well as some of the things that I think have made it successful over the years. So let's start about why I think it's important for all of us to think globally as orthopedic surgeons. It's important, I think, to start by not propagating traditional paradigms of north-south relationships and paternalistic attitudes towards global health. We're going to have to really think about being humble when we approach this problem. These are some statistics that may be familiar to a lot of you. I think you know that in the United States, we spend more money for worse health than any other developed country in the world. And we have unique problems, public health problems like firearm deaths that really distinguish us in a dubious way from the rest of the world. In the midst of this pandemic, I think we're also leading in a way that we would not like. In overall numbers of death and cases. Obviously, you all are very much familiar with this, but also I think that the pandemic has shown us that we have deep whole-scale inequities in our society that put many vulnerable populations at risk. And so I think when we look at the rest of the world and the overwhelming humanity that lives in countries that'll never benefit from the kinds of training and expertise that you all are developing, that we ought to also be open to the kinds of lessons that we might learn from working in other parts of the world. No talk on global health would really be complete without a description of the global burden of disease. This is a project that has been going on for over 2 decades, funded mostly by the WHO. We've identified that at least 30% of the global burden of disease is potentially surgically relevant and surgically treatable. We also see that when we look at low and lower middle income countries, that the burden of mortality due to injuries is greater than the combined mortality from HIV, malaria, and tuberculosis. And anybody who's ever spent time in an austere environment in a low or middle income country and tried to cross the street can understand why this is such an enormous burden. And sites like this are unfortunately not too uncommon, and really put populations at great risk for these road traffic injuries that have become such a problem. And I've been talking about mortality, and most of us as orthopedic surgeons don't go into orthopedic surgery to think about mortality so much, but I want you to recognize that these numbers are just the tip of this injury pyramid, and that for every one death, we have 20 to 50 disabled persons as a result of road traffic injuries. And let's think then that who are these patients that trauma impacts most? Well, they're the poor. 90 to 95% of injury-related deaths and long-term disablement from injury occur in low-income and lower middle-income countries. And that is a really staggering statistic. If any of you can remember a busy night on call at one of your hospitals, the volumes that we see are nothing compared to what the rest of the world is encountering. And it affects the poor. It affects the young. So trauma is the #1 cause of both death and disability for young folks around the world. And not surprisingly, men, as they are in this country, and are disproportionately affected, particularly in road traffic accidents. Road traffic deaths and injuries cost a tremendous amount of money, up to 5% of GDP of many low and lower middle income countries. And then it is surprising that these problems receive so little attention from funders globally. We see less than 1% of all global health dollars go towards dealing with trauma. So we have a large unmet burden of disease. We have limited access to modern surgical care, and funding is lagging, right? And what are the needs then? Well, there's a need for injury prevention. We need to improve trauma systems. We need to improve infrastructure. And obviously there's a need for surgical care and rehabilitation programs to reduce disablement. And many of you are probably scratching your head thinking, well, what does that mean for an orthopedic surgeon? And that's what I thought a lot for a long time. I really struggled with these problems that I thought were incredibly important, but I had to reconcile this with my love for surgery and orthopedics. Well, I think it's obvious that we have the greatest role to play in tertiary prevention of longer term disablement, secondary to musculoskeletal injury and musculoskeletal problems in general. And I think this over the last 50 years has led many orthopedic surgeons with very noble intentions to get involved in surgical missions. Unfortunately, they're limited in capacity, follow-up is poor, and there are real questions about the sustainability of these kinds of programs. And this really led us to start thinking about how we could engage global partners in longer-term partnerships. When I was a resident, one of my mentors, Rick Coughlin, and several of his several of his associates were interested in starting a program that was committed to partnering in academic partnerships, and started a not-for-profit departmental initiative that we called the Institute for Global Orthopedics and Traumatology. And I'll tell you a little bit about the IGOT model. So IGOT's mission is to build capacity in musculoskeletal care through global partnerships in low and lower middle income countries. And we have three main pillars. They're education, research, and leadership. The executive team here are all incredibly valued partners that I've learned a lot from, and none of the work that I'm talking to you about here would be possible without their efforts, as well as a really dedicated full-time staff. We also have IGOT faculty outside of UCSF who we partner particularly with in our educational endeavors. I'm going to tell you a little bit about the three pillars of IGOT. And the reason I'm going to talk, I know this is a talk about primarily about our research platform, but I'm going to argue that our success, if we've been successful in research, has really been related to the comprehensive approach that we've taken to building relationships over time. And so I'll start then with education, because it is one of these core pillars. We have a global elective for our residents, and we host a visiting scholars program. I think that this was a survey of general surgeons, but I think these numbers reflect the attitudes that orthopedic surgeons have as well, that particularly trainees have in being interested in international rotations, and actually will be a willingness to prioritize those experiences over many of their opportunities for training at home. You've heard a little bit about our program from Heather Roberts, who spoke earlier, but we have sent our fourth-year residents on 1-month blocks for over a decade now on a fully departmental funded elective to 6 different sites in Nicaragua, 4 sites in Africa and in Nepal. We currently continue to have relationships with 3 of these sites. These programs were built up around orthopedics overseas programs. They typically were vetted by members of our department before sending residents over, and continue to be one of the most highly rated educational experiences that our residents participate in. Over a decade ago, one of my co-residents looked at studying the impact of this global elective on future practice patterns from the perspective of our residents, and found that these experiences were strongly correlated with ongoing commitment after training to service activities as well as overseas activities. But it really didn't think about our hosts. And again, you heard Heather talk earlier about the survey that we conducted with a large coalition of North American academic centers that have overseas relationships, and found that there is some discordance in the expectations and motivations, primarily being that our trainees tend to participate and seek out experience, whereas our partners really value the relationships and potentially research collaborations that come of these relationships. So it's important, I think, that we think about reconciling those in our research and educational activities when we partner with institutions overseas. These results were echoed by a systematic review that was conducted by Heather and one of our other research fellows, looking at what the literature shows in terms of this concordance or discordance, and found really very similar findings that trainees from high-income countries are altruistically motivated, but they're thinking about professional development, whereas our partners overseas are really looking for sustained collaborations and educational opportunities. The takeaway message from this series of studies was that for high-income residents rotating in low and middle income countries, we need to make sure that they're prepared before they go. They need to stay long enough to really make a meaningful impact and cultivate those relationships with a sense of cultural humility. Now, we've also partnered with institutions overseas in exchange programs, and we've had over 100 global scholars visit us from overseas in San Francisco over time. Now, this hasn't always been the most economical way, and I think about 10 years ago, we started thinking about a more economical and efficient way of delivering education to our partners overseas. We have developed a series of short courses that primarily focus on open fracture management and soft tissue reconstruction. We partnered with plastic surgeons both at our institutions as well as around the country, and put on now more than 20 courses in country in 4 different countries, and educated more than 1,000 attendees. This was our last SMART course that we held in Tanzania. Unfortunately, we had to skip this year. The global pandemic has an impact on a lot of things, and one of those is our ability to travel and go to our learners overseas. And we have responded to that with taking the SMART course online. In fact, we're currently, actually today, conducting the virtual SMART course for learners from around the world. We've also had the opportunity to develop an online learning portal. One of my partners, Paul Toogood, has really developed an amazing suite of modules within this portal that I'd encourage you all to visit. It's based on the edX platform, and it allows us to put on educational modules that include videos, lectures, etc., and has also become a really valuable tool for studying the efficacy of our research efforts. So this brings us to our global research initiative, and this is really the meat of the discussion and what I'd like to present to you all today. It is built around 3 components. One is research methods training. We also are involved in collaboration on questions relevant to our local partners. That's really what we strive to do, is not answer our questions per se, but to help our partners develop studies to more effectively and relevantly answer the questions that are mostly important to them. And obviously part of this is capacity building. Really, our end game is working ourselves out of a job here. Once we build the culture, we hope that someday that all of our partners will have the capacity to run research studies on their own and answer their own questions. So let me tell you a little bit about our research training program. So for more than 10 years, what we've done is coupled our SMART courses with short courses in research methodology, and we've conducted these overseas now, as I mentioned, for almost a decade. We also have an international research fellowship. This has been made possible through generous contributions from our alumni society at UCSF, as well as one of my partners, Trig McClellan, the Doris Duke Medical Foundation. We have a relationship with the GloCal Health Fellowship Program that's funded through NIAMS, as well as Operation Rainbow. And this is a program that allows us to take 1 to 2 medical students or residents a year and help cultivate their interest in becoming global health and global surgery leaders. Even in the time of the pandemic, unfortunately, we don't have the ability right now to send our fellows overseas, but we're still meeting regularly and virtually. This is our hierarchy. This is how we think about this is how we think about approaching research with our global partners. And it really emphasizes the importance of formative work, of qualitative research and sound epidemiologic studies to really understand what's most important to our partners, to understand what's most important to their patients before we launch into expensive and time-consuming interventional trials. So I'm going to use our relationship with our Tanzanian partners as a case example. This was established in 2011, and it was built on the back of one of our most popular resident rotation sites. We have since partnered with our colleagues at the Muhimbili Orthopedic Institute on 7 SMART courses, and are involved in numerous multiple large research projects. It started with building that relationship on the back of an educational commitment and exchange program with the folks at Muhimbili. We asked a lot of questions. We listened to what their problems were and their questions were. And we started with some of these questions, each of which, by the way, have blossomed into a research study of their own, led again by our partners. So we asked questions like, what is the incidence and burden of femoral shaft fractures? Is surgery better than skeletal traction for the management of femur fractures in austere environments? What is the cost effectiveness of surgery? Does it make sense to do these studies? What is the indirect cost associated with care for long bone fractures? So many of the patients that sustain these injuries when managed non-operatively lie in skeletal traction for months on end in hospitals, and that's a great consequence to their own caregivers who are typically friends and family members. So trying to really estimate the burden and indirect cost of managing these problems. How are open fractures management, and what are their outcomes? All of that had to be asked. Those questions needed to be asked before we could arrive at some of the questions that have motivated larger prospective trials, looking at IM nails versus plates for femoral fractures, looking at open fracture management and comparing different treatment modalities, and asking questions like, are local antibiotics effective strategies in managing or mitigating the really devastating consequences of open fractures. This was the first large prospective trial that we ran, and this was published in the JBJS. And I think it was an interesting study for many reasons. One is it was really the first high quality prospective cohort study looking at femoral shaft fractures managed primarily with intramedullary nails. Demonstrated their safety. I think it also demonstrated to us how we could be successful in running these kinds of trials, how we set up the infrastructure to do a trial like this. We were able to achieve better than 80% follow-up at 1 year, which was shocking to us as well as most people, I think, who read this study, and really motivated and encouraged us to ask more questions and to try to do better. And the next set of large-scale trials that we conducted have been randomized trials. We conducted a prospective randomized trial in which we randomized 240 patients to uniplanar X-fix versus locked IM nails. So there's a great reluctance in many parts of Africa and other austere environments about the safety of using IM nails, particularly sign nail in this case. And we were interested in understanding reoperations as well as a host of secondary outcomes, including patient-reported outcomes and radiographic outcomes. And we recently published the results of this study. There was no difference in reoperation or deep infection. Again, I think a surprising finding, potentially related to a lack of power. We did find secondary outcomes favoring IM nails, and overall showed that medullary nailing, even in the setting of open fractures, is safe and can be done effectively. Studies like this, I think, are interesting to compare if you look at our ability to enroll open fractures over the course of 1.5 years. It really demonstrated a point that I made earlier, which is that a busy trauma center in East Africa enrolls 5 to 10 times as many open tibial fractures, for example, than any of the busiest trauma centers in North America. So attests to the staggering rate and incidence of these really devastating injuries, and moreover demonstrates our ability to build the capacity within a center like this to study these problems. Each of these trials has resulted in data sets that have been useful for both our research fellows and residents, as well as trainees in our partnering institutions. Abby Cortez, I'm just going to give a shout out to her because we're virtually at UCLA today, and she's one of our current year-long fellows, and she's working on a follow-up study of this open tibial trial, in which she hopes to study these outcomes at 2 to 5 years of follow-up. I think it would be a very major contribution to the literature. We're also adding economic analyses in addition to the clinical and radiographic outcomes that we're studying. And I think a lot of you might wonder how do we do this? Is Morshed in Africa for 12 months a year? No, I'm not, and neither are my IGOT partners. These studies run themselves now. We've built an infrastructure in Muhimbili that is incredibly competent. These are our 3 full-time research coordinators in Africa who do a phenomenal job running these trials. I visit one or two times a year, as do any of my partners, to kind of check in. We'll be there when we're doing educational courses, hopefully sometime again in the future. But this is just a testament to the ability of our partners to learn and to develop an ongoing infrastructure for research. Our partners take primary role in disseminating the results of these papers. This is Billy Aonga, who is the lead author on our open tibial trial, presented and won the international award at the OTA a couple of years ago. And so we're really committed to the professional and academic development of our partners, and I really think this has enabled us to cultivate these long-term relationships. Now, I've talked a lot about trauma. Trauma is what I do, but we have members of our group and partners that are involved in studies looking at orthotic and prosthetic interventions. Pediatric orthopedics is obviously a very important area within the developing world. We're setting up one of the first arthroplasty registries in sub-Saharan Africa, and we have an oncology registry in the works as well. And again, this is a department-wide initiative. This is not just restricted to our trauma group. Colleen Sabatini has a center set up in Uganda studying post-injection paralysis and gluteal fibrosis. My partner, Ted McLeod, has led our efforts in Latin America, was recently awarded an R01 in collaboration with McMaster to extend the enormous study that's looking to better understand the global burden of musculoskeletal injury in Latin America. And you can imagine that this all creates a fairly rich portfolio of research projects that benefit our residents. And we've got one or several residents in every one of our classes that are now involved either in in one of the primary studies that are listed here, or are benefiting from the secondary data analyses that can be undertaken with data sets that are collected, again, always in partnership with our colleagues in country. It's hard to, I think, quantify the real impact or accomplishments of a program like this. Certainly you can look at peer-reviewed publications, and we have quite a few that that involve UCSF trainees or faculty as co-authors. But I think one of the really encouraging things that we've seen is that that we're building this culture of inquiry and critical appraisal that's led many of our partners to undertake many studies now on their own without our help. And like I said earlier, this is kind of the end game for us, is building capacity and working ourselves out of a job. And it looks like in some of our partnering sites we've been fairly successful. The third component or pillar of our program is leadership, and I think this goes hand in hand with the research and education programs that we've been developing. We're always looking to identify local leaders and support them, and we are also trying to take the brain trust that we've developed, the experience that we have collected over the last couple of decades, and use that as a model to promote this cause amongst other institutions in North America and Europe. An example of this is the Actuar program that we've been developing over the past several years. We have a leadership training program that we ran last year at the Mexican equivalent of the American Academy of Orthopedic Surgeons, and had 30 Latin American orthopedic surgery leaders from 5 countries participate. The COACT Consortium is a project that we launched in 2016, and the idea here again was to take the experience and knowledge of programs like ours that have successfully partnered with developing nations' orthopedic societies to share educational programs, best practices, and research in order to foster collaboration. And I would encourage anybody that's interested in anything I've had to say today to go visit our website and to see how you can get involved. We a lot of the process of setting up research is laid out there in different resources that we've put up on the web. Now, is any of this legal, and who pays for it? I think that if you're at an institution that doesn't currently have a global orthopedic program, these are good questions. And I'll give you in a nutshell kind of how we've approached these questions over time. And a lot of it has been kind of hand-to-mouth learning as we've gone through this. But again, a lot of this is laid out in resources that we put up on the COACT website. So feel free to find those there. I think that implementing an educational program relies a lot on the involvement of your partners. You need to have individuals that you're partnering with overseas that sit in positions of sufficient power to create these collaborations. These kinds of collaborations really require at this point MOUs and professional service agreements. It depends a lot on whether your program is going to be purely education based or whether there's going to be any clinical component to it. So these are important considerations that we can talk about for hours and hours, and it's not super exciting. So I'll direct you to the COACT website. I think when we talk specifically about research and funded research, that it's going to ask the investigator the important question of whether we have partners who have, for example, post-award programs at their institution. Do we have the ability to disperse funds in Ghana or Tanzania with our partners if we have a funded research project? How is it that we're going to pay coordinators, for example? These are, again, these are important considerations, and they do take a bit of navigation through a morass of legalese that I think a lot of our institutions are becoming more savvy to now. And if there's interest on the part of anybody on this call on how to navigate this or set a program like this, I'm happy to follow up over email or over a quick call at another time. Funding is critical. I don't think you can start a global research program or a global orthopedic initiative, for that matter, without some departmental investment up front. You need the political will and the support, the financial support of a department to get this sort of thing off the ground. We have been fortunate enough to benefit from individual donors. A lot of them are our own alumni, grateful patients. We've also cultivated relationships with industry and garnered some corporate funding over time as well. And I think research grants have increasingly kept our ship afloat. We've certainly gone through ups and downs and had to weather austerity of our own over time. To date, we've raised over $2.5 million to support IGOT and IGOT's educational and research initiatives. I'd like to say that if we're not always completely independently funded, we're getting very close to it right now, particularly on the part of our research initiatives, which are now fully funded through some of these organizations. So let me finish now just by summing up what I think have been some of the successful elements and critical elements to our program. So we talked about institutional support as the start, and I think that really enables a motivated set of individuals, be they trainees or faculty members within an institution, to garner funding independently. We also talked about the importance of partnership and communication between strong partners and passionate faculty members in sustaining these programs. A culture of humility and a commitment to reciprocity really underlie all of these programs, and I don't think you can succeed without them. Educational programs should be bidirectional and need-based. Our research program should focus on host-derived questions. We need to be committed to ethical conduct in our research. We need to build research capacity, and we really need to credit our partners with dissemination of their work. It's their hard work. It's all of our hard work, but I think too often the work that is this kind of work that's been done has not adequately acknowledged our partners overseas. Finally, I think we need to be committed to the professional and academic development of our partners. And we need to share and learn from other institutions in engaging in global orthopedic work. So check out the COACT website if you're interested in any of this. In summary then, there's a large unmet need for global care globally, and I hope I've piqued your interest a little bit in thinking globally about how your career as an orthopedic surgeon may impact musculoskeletal health globally. Academic institutions, which you're all a part of now, are uniquely positioned to partner for training, research, and leadership development, and a commitment to mutual benefit, institutional buy-in, and strong local partnerships, as well as the development of independent funding, I think are key ingredients for sustaining your programs and being successful. Finally, I'd like to acknowledge my partners, again, Rick Coughlin, Ted McLeod, Dave Shearer, and all of our IGOT staff who've worked tirelessly. If any of this has been successful, it's in no small part to them, as well as some of our funders whom we've already acknowledged. With that, I hope I haven't taken more time than I was allowed, and I would love to take any questions. I know that some of you on this call are probably involved in programs of your own or in various stages, and I'd love to learn from you if there's something that I've left out. Thanks very much for your attention.
Thank you, Sam. That was fantastic. I really hope that the residents will get the same kind of inspiration I feel for finding their passion and continuing on and building such an incredible program. We do have time for a question or two if someone wants to enter it on the chat. I did, Sam, I actually wanted to ask you, we obviously have a lot of really smart and driven residents on the call. Our resident Abby mentioned that you're trying to build out the COAC resident portion of that. Can you speak a little bit about their opportunity to join that?
Yeah, absolutely. So there's a COAC resident group and a page that was started a couple of years back, and it's a great clearinghouse for different opportunities, both clinical and research. We're always looking for new resident members of COACT because, like residents do, they finish their training and move on, and they're no longer residents. So we're always welcoming new residents into the legion of resident members of COACT. And if you're at all interested, again, visit the website, reach out to me. Happy to talk more about it. But your inspiration is really vital. I can't tell you, I mean, almost every single one of these projects, while they were inspired by our global partners, they were almost all carried forward on the backs of some of our residents. My partner, Dave Shearer, was my resident, and he was the one who got the prospective trial on femoral nailing off the ground in 2011. And that was really the start of it. So you guys play a huge role in the ability of these kinds of initiatives to be successful.
Great. We have a question from Dr. Lin, Sam. A lot of us have these rotations out off-site. What do you think is the right amount of time to really kind of do the relationship building that you're talking about is so critical? Yeah.
So this is, I'm quoting Heather's work here because that was a question that she asked in her study of our global partners. And the feedback we have is that they ought to be longer term relationships. So, kind of a 1 week. Now, I can't give you a specific threshold. 1 week's probably not enough. Really getting more than 2 weeks, ideally a month. You can't take a lot more time than that as a trainee or as a faculty member. To go off and do your work overseas, but the sense is from our global partners that the longer the better. Those really satisfy their need for the kinds of relationship building that really meets their expectations, and I think it really is critical for our residents as well. I think that most of our residents would say that 1 week would never be enough to get nearly what they get out of a 4-week experience in terms of the relationships they build, the understanding of the kinds of pathology and problems, as well as understanding how problems are solved in austere environments without a lot of the tricks and tools that we have available to us here.
Well, that's great. I think we're going to have to kind of move on to the word section. I see a question from Brendan Mitchell. Reach out to Dr. Morshid. I'm sure he'll be happy to talk to you.
Absolutely.
So, again, I really want to congratulate all the residents. This is really inspiring for me as a faculty member to see your energy and the quality of the work that you've done. I just want to congratulate you all. I also really want to thank the OREF. I, like many other panelists on this conference, owe a great portion of my career to the OREF, and I really feel that debt to them. So we're going to go ahead and move forward with the announcement of the winners. There are cash prizes, which I'm sure everybody's happy about. We have 3 third-place winners who will be receiving $500. The first is William Rubenstein from UCSF. Congratulations. I guess if you win, you got to turn your camera on.
Thank you very much. Appreciate it.
Great. Don't spend it all in one place. Okay. Next is Akash Shah from UCLA. And our final third-place winner is Max Giganti from Good Samaritan Regional Medical Center. So great job to that group. We have 2 second-place winners at $750 each. Obijala Aga from UCSF, congratulations. And Zachary Burke from UCLA. Congratulations to both of you, great job. Before we get to the first place winner, we have the presenter's choice. So this is voted on by all the residents, and this is a $600 prize. Goes to William Shepard from UCLA. Congratulations, Will. And our final award winner in first place at $1,000 award is Rishi Trika from UCLA. So congratulations, Rishi, and congratulations to all of you. Just really outstanding work. I couldn't be more proud to be part of this, and wish you all well. Thank you to all our judges and our keynote speaker. Great job. Carmen, does someone from OREF want to close the conference for us?
Hi, I'm not Carmen, but I'm Deborah, and I just want to say that thank you. I thought this was awesome, and I really enjoyed it. We weren't sure about this format, but it worked. So thank you all for all the work that you did to make it work. Everybody will be receiving an evaluation form, judges and presenters, and we would really appreciate it if you would give us your feedback, as that will help us with the next ones that we do. And also, those of you who were announced as winners, you need to send your mailing address. We have your email address. Carmen needs your mailing address if you're going to get your check. Thank you, everybody.
All right, congratulations and thanks, everybody. Have a good rest of the day.